the data are analyzed, and there's tissue and organ characterization, normal and pathological feature extraction. Ultimately, the idea is to integrate some of these imaging features with genomics and function, and applying it to clinical applications, which are real world problems, and basically would transform the lives of humans in the next several decades, possibly. There's a significant component in the Center for Intelligent Imaging on education and outreach. I'm just putting it out there. So if there are students and postdocs and interns who are interested, but I'm going to go back to the first three pillars right away and tell you none of these are done in isolation. If images are acquired, they might be segmented while they're being acquired. The acquisition may be modified thereon. That's the principle of the Center for Intelligent Imaging moving forward. Now, Miguel introduced me, and you know that osteoarthritis is one of the key areas that I work on, and I'm going to use that as my disease model to actually show how the strength of artificial intelligence and going across the imaging cycle and into precision medicine for directed patient care. So I'm going to bring out all those potentials. Osteoarthritis is a degenerative disease. It is a leading cause of chronic disability. And I dare say many of you are suffering from knee or hip pain even at the moment. There are features such as your gender and race, which affect the presence of osteoarthritis and the occurrence. And it is typically measured in terms of pain, stiffness, limited joint function during daily life, which reduces an individual's quality of life. And these are patient-reported outcomes, which patients or subjects report. The FDA accepted determinant of osteoarthritis is radiographic images, and radiographic images reflect the joint space, the presence of these features called osteophytes, but they only represent the bony changes. Magnetic resonance imaging is an emerging, it has emerged over several decades now, but it is certainly very applicable to osteoarthritis. It reflects the soft tissue composition of the entire joint. In this case, I'll be talking primarily about the knee, and it actually reflects the tissue and the organ changes and the joint changes that are occurring in osteoarthritis. Images can be of different contrasts and can show different lesions. This is the cartilage, and the cartilage usually degenerates in osteoarthritis, but there are other tissues involved. You're looking at MR images showing different features of degeneration. These are the same image of the same knee, but obtained in a different plane and with different contrasts. So a large number of features can be seen using magnetic resonance imaging, and that's why it is such a valuable tool for the understanding of osteoarthritis. Contributors to pain and osteoarthritis are poorly understood. Basically, with osteoarthritis, there is a degeneration of the articular cartilage. For those of you who are not familiar with the field, the bone also shows some changes. The underlying bone, there's a meniscus or a tissue which also undergoes certain changes. The ligaments which hold the bones together are also often injured or have changes in them. And the ultimate outcome in osteoarthritis is total knee replacement. It is an extraordinarily prevalent disease. 52.5 million adults have self-reported or doctor-diagnosed osteoarthritis. The scary thing is by 2040, the numbers are expected to increase drastically. And it is no longer a disease of the aging. And the reason for that is there is a class of osteoarthritis, which is called post-traumatic osteoarthritis, occurring as a result of ligamental injuries like ACL injuries. Sports people often get it, and other injuries to the meniscus and other tissues. So moving forward, what is the determinant of osteoarthritis? Pain is considered the primary outcome, and there are questionnaires which are used to determine this pain, which patients actually report. And these are just a listing of some of the questionnaires that exist. The knee osteoarthritis one is the one that is relevant for knees, and they are sort of subjective questionnaires asking folks about their daily living, whether their life is hampered as a result of the pain. These questionnaires, although widely used and I used as one of the metrics, are highly subjective. I have filled them in depending on my mood. I can be either mild, moderate, or severe in terms of my pain. They are non-reproducible on a long-term basis for the individual, again, for the reasons I said. And many of them say in the last 7 days, in the last 14 days, and they record the pain over a limited time. Let's talk a little bit about the X-ray assessment of knee osteoarthritis. These are some radiographs that you see on the all the way on the right, and they show the features such as joint space narrowing and osteophytes. And these radiographs are typically graded using the Kellgren-Lawrence scale. If you were there yesterday, you heard about it and the appropriateness of the scale, but nonetheless, it is a scale that is accepted. It is a scale that is used in the Osteoarthritis Initiative. And I want to introduce in a few minutes what that is, and we can talk about it. But the Kellgren-Lawrence scale is essentially a scale that grades the joint, and you start looking at it for grade 1 being mild, and then all the way to severe, where there's absolute joint space narrowing and the joint is totally macerated and severe osteoarthritis. A lot of these are graded using radiologists grade them. It reflects the late stage of bone changes, but we have developed and others have developed AI algorithms by training basically training the model to identify the Kellgren-Lawrence scale grades in radiographs. The way we've done this is there's a vast data set known as the Osteoarthritis Initiative, which includes radiographs, demographic data, MR images, patient-reported outcomes, and more in a subset. There is even genomics. Using this data set for training as well as for validation and testing, the Kellgren-Lawrence scale algorithms have been developed, and they perform almost as well as the radiologists with a kappa of about 0.84. However, these actually only reflect late bony changes, and we can talk a little bit more about that in a minute. In the context of joint degeneration, we've already talked about the different types of osteoarthritis that may be prevalent. Some of it may be age-related, some of it may be post-traumatic, but they're all joint degenerative changes. MR imaging provides excellent tissue contrast for all of the tissues involved, such as the cartilage, the ligament, the bones, the meniscus, the bone marrow, and even the muscle. Quantitative imaging in MR is a way of looking at tissue composition and changes in the cartilage biochemistry, which also occurs as a result of osteoarthritis. And the association of imaging and function and pain with these quantitative parameters actually opens up a huge area for precisely quantifying the disease and precision medicine in joint function and osteoarthritis. And in this case, one can then go beyond simple multivariate analysis, and translation to the clinic can include artificial intelligence and big data analysis. And I hope I can bring to you some of the ways that this can happen in the future. So we talked about imaging. Let's talk a little bit about what are the things I'm going to be talking about in terms of quantitative imaging. In terms of quantitative imaging, there are changes in the cartilage, meniscus, and all these other tissues. These are typically graded for morphology by radiologists as mild, moderate, and severe. That's one kind of there's a lesion, the cartilage is thinning. But over and above that, MR images can be used to look at bone shape, the thickness of the cartilage, whether there's meniscus lesions and loss of the ligaments. And within the bone marrow itself, within the bone itself, you often see lesions which are reflective of osteoarthritis. And we talked about MR and its potential for looking at cartilage composition, ligament composition, and so on. Ultimately, osteoarthritis and joint degeneration affects skeletal biomechanics, and patient-reported outcomes are clearly one outcome, but there are also changes in biomechanics and skeletal loading, but we are not going to talk about it in this particular talk as much, but these can all be wrapped in using AI. And of course, ultimate goal is to predict who is going to need a total knee replacement, but doing that much earlier. So my focus today is to address emerging precision imaging methods that relate joint morphology, composition, and function that provide non-invasive imaging metrics related to pain. I won't address function today. We'll talk about the clinical translation, and the ultimate goal is to reduce disability, the number of joint replacements. And in all of this, the essential potential of artificial intelligence. The clinical workflow in MRI starts with when the patient is first referred for an MRI. One needs to provide protocols. In many instances, this protocol is provided by at least one FTE does the protocoling all the time. The time estimated for the scan is established. MR scanning begins. The image location has to be determined as to where are we going to obtain these images, the image prescription. The radiologist is called in, and you want to make sure if there are questions about image positioning, and if they aren't available, often there is rescan needs. And after that, the image is acquired and large numbers of images are obtained. The images are read and the report is generated, and so on. Before I go on to the next slide, if we can eliminate and reduce the time taken for some of these tasks, such as providing the protocols and ensuring the correct positioning and the radiologist's time, I think it would have an immense impact on clinical workflow for MRI. So we began doing this by looking at our databases, and I'm just showing you here an example of the brain, but the same applies for knee imaging as well, by using natural language processing based on what was actually requested, what was the condition that the requisition was coming for, and how the protocol or the number of MR images and the contrasts that were required to be obtained. We essentially developed a automated protocoling system. And this automated system uses natural language processing, converts the text to numbers using a bag of words, and basically does multi-label classification of the feature vector. And for the brain, we have about 88% accuracy. We are now assessing this for the knee. We will be assessing this for the knee. So this is an amazing application which improves the workflow. The second application, I want to show you what is typically done in an MR scan. If you've had it, you hear very fast images being acquired initially. A lot of localizer images are acquired. And after that, the actual region to be imaged is actually selected off of these three planar images. And this is done manually by the technologist, often verified by the radiologist. Again, depending on the reason the person is there for a scan, we have developed a automatic oblique prescription model, which can take essentially these localizers, put bounding boxes, and the teal and the dark blue boxes on these are those that were actually prescribed by the technologist, and the dark blue is by the model. You can see the model is performing really well, and the graph over here shows essentially the center position and the tilt angle that the automated algorithm develops. So there's an automatic prescription which essentially does the prescription based on the condition, which this is AI, again, impacting the workflow. But let's talk about the images themselves. The number of images that a radiologist read is increasing exponentially. As you see on this graph on this right-hand side, it's been growing every single day. The scan time is reducing. More and more features are being developed to reduce scan time. So what's happening is that the number of images that one can actually acquire is also increasing, but the number of cases are increasing. And for a radiologist to quantitatively grade all these three-dimensional stacks is really not possible from that perspective, even though these cross-sectional images are far more interesting from a radiology point of view than the radiographs themselves. But the radiologist currently is not doing and taking advantage of a lot of advanced imaging tools. For example, not identifying or segmenting the tissues of interest, finding their morphology by way of quantitative volumes and thicknesses, quantitative imaging for chemical composition of the tissues themselves. The grading is often not standardized, and we'll talk a little bit more about this, between one radiologist grading something as partial or mild versus severe. And the tissue characterization that is possible with MR is not being taken advantage of. This is where I think artificial intelligence, machine and deep learning plays an enormous role. So let's start with what can be done with artificial intelligence along these lines. You have probably seen a large number of knee segmentation challenges. We have robustly participated in all of these for segmenting out cartilage from MR images. I show you results here from one of our ensemble models, which won third place, I think, in one of these challenges, which provides accurate segmentation of the articular cartilage. And if you can do this really rapidly without having intervention from a technician or a skilled radiologist, I think you can start measuring cartilage thickness, volume, and other features. Using these image segmentations, one can also look and examine the cartilage and see, is there thinning, is there a lesion? And essentially, the other issue that MRI requires is a long scan time, and I'll be addressing that a little later. So image segmentation is possible. We can also segment tissues such as the meniscus, as well as the bones, using magnetic resonance imaging. And again, there's a wide range of literature which is there right now. But let's talk a little bit about lesion detection. Can we, in these MR knee images, automate or assist radiologists in MRI readings? MRI are obtained on multiple scanners, and there are multiple compartments in the knee. We talked about the knee, but there's the femur bone in the knee, there is the tibia, there's the patella. Each of these bones are covered with cartilage. There's meniscus associated with the tibia femoral joint, and there are different ligaments associated. So there are 6 cartilage compartments that we deal with, 6 bone compartments that we deal with. There are 4 ligaments and 6 meniscus compartments. There are lesions which occur in each of these compartments, and they have different relevance in terms of their importance and their clinical significance. So using first some of our highly curated research data sets, we have developed a methodology for actually training a model, validating, and then testing a model for detecting some of these lesions. We have multi-class sensitivities, which range from about 70 to 89% for cartilage. It's different for menisci, bone, and ligaments. And I will talk about the model performance in a little bit. But what happens? You provide a model, you have 60 probabilities. How do we represent this to the radiologist, and how do we make it useful? This is one of the reports that we came up with, where we look at the femur, we look at the lateral femur, the medial femur, and we color code it. If the cartilage is normal, it's green. If there is a severe lesion, we actually put down a different color. And this is how we've actually represented meniscus lesions, meniscus being normal in a particular region, the probability of there being a lesion, either moderate or severe, and the ACL, whether it's surgical, post-surgical or not. These are some of the representations that we have developed based off of our probabilities and model output. This becomes very, very important for clinical validation, testing, as well as for deployment. Let's talk about the model a little bit. Looking at the model and looking at the heat maps, we can see the areas which the model is using to determine what type of lesion it is. I'm showing you results from the cartilage severity staging. It's a very busy slide. There are 2 radiologists, R1 and R2, and there's a third radiologist, R3. One of them is a trainee. I don't know which one at the moment. And there is the deep learning model that we've trained. If you look at it across the board, radiologist agreement between the normals is good. Our model performs almost as well as the radiologist. The partial lesion detection in the cartilage, the severity, the agreement is very variable. It's not that high. And full lesion is a little bit better than the partial, but again, it's not that high. If you start looking at a model performance, a model which has been used by using these radiologists grading performs almost as well, in fact, in some cases, better than the radiologists in determining the lesions. So what did we do with this? We did a study where we had 50 clinical MR cases, which were graded by a senior radiologist and 2 trainees. The readers independently and blindly graded all the cases without AI support. And if you actually look, the yellow are the weighted kappas, and you can look at the weighted kappas, it's 0.4. It's a little bit higher in the second case, but across the board for cartilage, for meniscus, all the tissues, the kappa gradings are about 0.4 to 0.5, 0.6 maybe for the ligaments. After a washout period, these radiologists were all given the output, something like which looked like this from the inferred models during a second round of AI-aided readings. And if you look, the postdoctoral trainee results actually improve significantly with the AI-aided results, bringing them much closer with the attending results. It's not perfect, but it is at least heading towards 0.6, 0.8% in many, 0.8, not percent, 80% in many cases. So it significantly improved their agreement with the experienced attending radiologists. So there is a role for AI guided decision making in terms of grading some of these images. I want to bring up the issue that the model is only as good as the data that you're providing, the training data. The fuzzy gold, it is a fuzzy gold standard in many of these cases. And a radiologist, you could say, is only as good as the training, but the training doesn't have, it's not a pejorative sense. It is really, it depends if your radiologist is only looking at knee images as a musculoskeletal radiologist or a general radiologist. The training is very different and the lesion identification is very different. So the question really becomes, how do we improve image annotation? This is one thing that we are really looking at very carefully, so that we have good consensus grading. Because in some instances, we've seen at excellent radiologists, a neuroradiologist and a musculoskeletal radiologist grades lumbar spine images very differently because they think of different aspects of the skeleton versus the nerves. Similarly, a general radiologist thinks very differently of the knee. The patient population often defines what they're looking for. Somebody who's looking at elite athletes considers the knee very differently than somebody who's looking at a general aging population in terms of the importance and the severity of the lesions. So in order to address this, we use the SWARM platform. The SWARM intelligence platform is a platform which makes real-time collaborations easy for image annotations and enables people to make decisions together. So I'm going to start this, and this is just a replay of how radiologists get on at the same time, making a decision for meniscus lesions, where it's observed and the severity of it by basically by interacting with this particular platform. So we looked at this using 3 resident trainees and looked to get their majority vote for the identification of meniscus lesions versus the attending, and we got a kappa of 0.27. You keep going further and you do the swarm voting with the 3 residents, and then the kappa improved to 0.38. When you included more residents, then the kappa continued to improve. So this is one way of doing probably consensus grading or training, training, or not the radiologist, but at least coming to an agreement of a cumulative grade or a gold standard. So this is one methodology that we are using. The second thing that one wants to discuss is, what if we said that we will not use any lesion detection at all? We will use the MR images exactly as they are. Now, the osteoarthritis initiative, we talked about it. There are 5,000 patients who have been imaged over 8 years, and they have a variety of data associated with them. Of course, the demographics, the patient-reported outcomes and pain. They also have radiographs, MR images, and we are going to be looking at some of these MR images and radiographs. So we looked at individuals who underwent a first total knee replacement within 5 years, and then those controls were the patients who did not undergo a total knee replacement within the 5 years. Some may have never gone through it, others might have gone through it maybe after 5 years. And our data set was used to actually split up into training, validation, and test data sets. And what we found is essentially is shown in this very busy graph. The details of it are not necessary. The only thing we want to really look at is basically when you use the MR images in a totally data-driven way, is after training, this is the test data set, the MR predictions of who will undergo undergo a total knee replacement is the area under the curve is 0.83. With radiographs alone, it's about 0.8, and it's a little bit lower in this particular case. What we found, which was very interesting with the MR data set in particular, is many of these individuals who underwent total knee replacement within 5 years were actually subjects who had no evidence of radiographic osteoarthritis. So subjects who had no evidence of Kellgren-Lawrence scores or joint space narrowing in time 0 within 5 years underwent a total knee replacement, and the combined model was able to actually predict that there was in these groups some individuals who underwent a total knee replacement. So radiographs do not actually predict the occurrence or of severe osteoarthritis. And the reason is clearly the bone changes occur much later. And moving forward, let's talk about total knee replacements a little bit, because I've talked about it a little early on as well. Total knee replacement numbers are increasing. It is expected by 2030, this is going to absolutely exceed any obvious limits. This is a prediction. I know this is a model, but the numbers have been increasing since 2000. What does this do? The absolutely inflation adjusted cost of this is in billions of dollars. And by 2030, given that previous model, it is predicted to be about $50 million. So a 10% reduction in surgeries will have a major impact on healthcare costs, and the estimated reduction is going to be significant, not to mention the issue of patients' quality of life and so on. So there's a significant impact of this. So if there is any way we can help that, it would be really useful. We talked about the X-rays. We talked about what is possible with X-rays and bony changes. MR also shows you morphological changes or lesions, but these have already occurred. Osteoarthritis starts much earlier in the knee joint. There is a loss of the biochemistry, loss of proteoglycan and collagen within the articular cartilage, and MR methods like T1-Rho and T2 can actually reflect the changes that even if you have the full cartilage existing, this is the whole cartilage, but there are some regions which have very high values of T1-Rho and which predicts loss of proteoglycan, so early osteoarthritic changes. This can be done with MR imaging. This osteoarthritis data set also has the data on T2 mapping in 5,000 patients over this time period. And research typically uses these, but in the clinic, current orthopedic radiologists do not do relaxation time mapping because it is time consuming to segment, it is time consuming to do the fitting, and it is time consuming to look at the data compared to a normative database. So we use the data from the Osteoarthritis Initiative and segmented the articular cartilage. And the Osteoarthritis Initiative has a control cohort of patients, it has a cohort of patients that progresses, and it has a cohort of patients that has osteoarthritis or the incident cohort. So we looked at some of these, we segmented the cartilage, and this is Valentina Pedoya's work where she mapped the T2 relaxation time on a voxel by voxel basis by putting all the patients onto the same framework. And then this is the T2, these are the T2 values and controls in the osteoarthritis group and in the progression group, in the incident OA group. And the deep learning convolution network had a classification accuracy of 95.2%. Moving forward, what has been done with this by Valentina's team and Alejandro Morales, one of the graduate students who's just graduated, is basically linking some of these quantitative biomarkers to chronic pain. Chronic pain in the Osteoarthritis Initiative was defined as patients who reported pain, knee pain, aching, or stiffness over half the days of the month for more than 6 months within the 12-month window. So this was the kind of data that was possible to be extracted using artificial intelligence and looking at these data sets. The team was able to segment cartilage and bone. But after that, what happened was the bone was actually fitted for the bone shape. The bone shape was calculated and the shape modes were calculated. Cartilage thickness was calculated using the segmentations, and T2 values were calculated to reflect the cartilage composition. These were all fused using a spherical transform, and the groups of patients were actually divided into those that had pain and those that who did not have this kind of pain. And a model was trained, and then there was validation, and then there was testing. So these individuals found clearly that the area under the curve, the sensitivity, the specificity, and the accuracy are shown here for the different bone compartments for the cumulative model, which includes all of these quantitative features. And you can see the accuracy for the pain separation of the two groups. What they looked at is the GradCam activation maps as well. And in looking at those, we basically started looking to see what are the patterns. And we found that different bones had sort of different activation maps. These are early work pointing to a multifactorial combination of biomarkers which are behind chronic knee pain. So this is literally dialing down to the individual's patient's pain and the pain characteristics. So what is possible with AI and magnetic resonance imaging and all the data that can be collected? It is the comprehensive disease characterization or joint degeneration, which includes the demographics, the patient-reported outcomes, lesions, the compositional information. If we could combine it either in a data-driven way or in a feature-extracted way to predict who undergoes total knee replacement, or who is in pain, or who has severe osteoarthritis years down the road, that would be a very valuable contribution. But ultimately, our ultimate goal would be to deploy this into the clinic, into the radiologist's workflow, so that it doesn't disrupt the workflow, but it can be used for basically assisting them and for getting some of these results. First is the validation of this in the clinical setting, and then ultimate deployment. This is an integral part that one has to think of, and how this is going to work. Responsible AI comes into play here. Who pays for the cost of this comes in. So this gray box here is a huge question mark, and which requires research. But one of the things I haven't talked to you about is image acquisition. MRI images inherently take a long time to acquire. If you want to do quantitative imaging, such as tissue thickness measurements, or a segmentation, or calculation of T2, it still takes more time. But in MRI, what you do is you collect a lot of essentially redundant case-based data for a number of reasons. For resolution, to reduce the noise. So task-based reconstruction is something where we started looking at it at UCSF, led by Valentina Pedoya. She is looking to see if before the reconstruction with reduced case-based data, could the data be shared so that segmentation could be done simultaneously along with the reconstruction? So task-based reconstruction with shared encoding paths, and with a reconstruction decoding path. And essentially the results where we've looked at the dice coefficients for segmentation, where we've acquired only 25% of the case space, is of approximately 90%. So it is possible to do this kind of task-based reconstruction. And we can also start looking to see, is the image quality appropriate for lesion detection? And we've begun doing this in the spine, in the knee. And one of the issues that you come up with is if you acquire reduced case-based data and you don't have absolutely pristine resolution, this fine feature is a meniscal tear in a knee. This is the ground truth image of the fast MRI data set. And this is the reconstruction with reduced case space, simple just reconstruction. And this is the best case with the fast MRI data. So you actually have a loss of lesion detection. This was work which actually won the best paper from Valentina's group at MIDL, with Kay Young and Francesco Caliva leading the study, where they essentially had adversarial robustness training. They had the ground truth. This was the UNAT construction, and this is the robust reconstruction using this adversarial training in terms of detecting lesions. What is done is a perturbation is provided during the training process. You know what the perturbation is, so you can actually decode it, and the model learns how to handle these perturbations. Using this particular method, the lesion detection rate increased in a set of studies where they found 3 out of the 8 cartilage lesions and 9 out of the 9 meniscal lesions, an improvement over a simple UNAT reconstruction. So what does AI bring? AI brings faster workflow, faster image acquisition, faster image analysis, AI-assisted decision-making, so faster workflow across the board. It also introduces a standardization. If your trainees are improving as much as you're getting close to your attendings, then it is also creating expert trainees, but also standardization in terms of morphological grading in radiology itself. Also the extraction of quantitative features such as thickness and biochemical composition. It also makes it possible to actually deploy these tools worldwide, again, bringing health equity and having a global impact. So instead of reading films, this is the ancient trajectory of reading films on light boxes, reading films looking at terminals, and having totally hassled radiologists trying to figure out what to do with a stack of 10,000 images. This is what we are looking at for AI-assisted imaging of the future in osteoarthritis. What would this look like in musculoskeletal? The what if? What if you had all this data in such as age, gender, genetics, body mass index, you had the patient-reported outcomes, biomechanics, composition, all of these, and you could subdivide your patients into various groups as to who would progress and who wouldn't. This is using topological data analysis, but there are multiple ways of doing this, and predict who is likely to have a total knee replacement. Wouldn't it be great if we could detect osteoarthritis early, predict the combination of factors, gender, obesity, all of the imaging features. We haven't talked about some of the bone interactions, but also, wouldn't it be great if pain was no longer subjective, but fMRI markers of pain could be identified? And this is something that is ongoing in terms of lower back pain. There are some studies in osteoarthritis where functional MRI and resting state MRI are being used to locate pain in these kinds of conditions. And if those could be used all together to look at predict who has early OA, no early OA, and from the OA group, if we could separate how many years later an individual would have total knee replacement and those who wouldn't go for total knee replacement. So a simple visit to the doctor with knee pain would actually provide some of these risk factors and models. Is this a possibility? And yes, that's what we are heading towards, from image acquisition to precision medicine. And we have a huge team. This is only a selection of the people who've participated in some of the studies that I've shown you here, but it is possible. And it is not possible just for osteoarthritis. I've just used osteoarthritis as a model. This is possible for something like lower back pain. If you're looking at my interests, it's possible for oncology. It is possible for a number of different conditions. And I would be remiss not to acknowledge the grant funding that we've had from the National Institutes of Health, our collaborations we've had with some of the corporate entities such as NVIDIA and General Electric Healthcare in terms of moving this forward and moving these concepts forward. And I just want to thank you for your attention and for being here today to share the excitement that I feel in the potential of artificial intelligence in basically imaging. I've used MR imaging again as an example. This is possible for any kind of imaging, multimodality combinations. And again, I hope I've also underlined there are perils in the way one interprets the data that you get. And there are some challenges that we still have to meet. So there's enough work for all of the students and all of the researchers and everybody out there. So with that, I think I'm going to end my talk. And I'm very pleased to let Maria know that I've done it 1 minute before her buzzer even hits me. So with that, I'm going to stop for now. Thank you very much for your attention.
Thanks very much for that great talk. So please, we have time for questions. We have time for questions. So start putting your questions in the Q&A. And while we wait for that, I have a few questions of my own. I was wondering, when you were we were talking about trying to optimize sort of how you quickly subsample case space, and what is the impact on image quality. I was wondering, how do you balance, or what are the trade-offs between do you optimize for a radiologist, or do you optimize for an AI, and is that how is that going to play out? Is that obviously or is optimizing for one will guarantee optimizing for the other, or that's so
No. So right now we've done this for lower back pain, where we've looked at image reconstruction using a particular deep learning noise reduction method. And the way we've done that is to look at radiologists and looked at their preference at the images based on signal to noise ratio, ability to diagnose the disease or look for lesions, etc. And we've basically selected right now a particular mode of noise reduction with a particular type of pre-processing to assist the radiologists and with the radiologist's preference. But clearly, the field is wide open. The reality is the detectability of a lesion of the model could actually be it may be better in some cases than the radiologist, depending on the radiologist training, the time that the radiologist has to look through all the compartments. So we actually haven't made the decision. The decision, I feel, will be guided by the field, depending on what we are trying to do and how much people adopt our methods of lesion detection. So there is a outcomes piece that needs to be done here, right? Before we translate AI and decide on the model. This is where the discussions of yesterday with continuous learning, with transfer learning, how these models perform in different populations will all have to be taken into consideration. And I'm not really sure what is going to be given primary weightage. It is really going to depend on the question we are trying to answer and how this tool is going to be used. If it's going to be used for decision support, then probably we want to be as sensitive and pick out as many lesions as we possibly want. But I've also heard radiologists say for breast imaging, for example, for God's sakes, don't light up all those lesions. They're completely irrelevant. So I think the model training will have to go on. This is not going to be a static model. I think the concept of federated learning and continuous learning will have to be engaged, and we will have to do this as a community.
Okay, great. Thanks very much. So here we have our first question from the audience. Does AI always outperform a radiologist? How much does this depend on the granularity of ground truth?
No, it does not always outperform a radiologist. It does depend on the ground truth. For example, the radiologist's agreement for determining what is a partial lesion or a partial cartilage tear, that agreement is that agreement between 2 or 3 or multiple radiologists is also poor, because it's a very subjective grade, and a partial tear versus what is normal, these things vary. So it does depend on the granularity of the ground truth. And just because an algorithm outperforms a radiologist in one of the validation, in the test sets that I showed you, I would be, as a PhD, would be totally crazy if I told the radiologist my model is better than you, because the reality is, in the radiologist's assessment, the radiologist looks at the lesion very carefully and critically over years, looking at essentially what is the rest of the context of the injury. Is this normal? Is this accompanied by something that is completely known and age-related and has no clinical significance? So there would be a lot of those kinds of things. So it does not always outperform. It does depend on the granularity of the ground truth, and certainly does not take into account all of the comprehensive issues associated within a single image or the individual's clinical background. So keeping that in mind, there is a lot of work to be done to make it absolutely perfect and be the perfect predictor.
Great, thanks. Here's another question. Very nice talk. how do you ensure that the models are not dominated by a majority population? I imagine in the training set, and there is sufficient diversity to appeal to all subpopulations.
We don't know that yet. There are very few large, diverse data sets. For example, the diversity that exists in the OAI was the diversity that was in the recruitment now maybe 15, 20 years ago. Yeah, easily 15 years ago for sure. And that diversity was based on the diversity that existed in Rhode Island, in Pittsburgh, and in the various places, 4 centers that recruited these subjects. And we have that data set. Our own research data sets are affected by the diversity that exists within the Bay Area. To make these models far more generalizable, we have to have test data sets in other diverse populations and build these data sets and look into it. One of the things that we found is in the radiographs, looking at the KL grading, the radiographs actually were just as it could predict KL, it could also predict gender and race. Gender and race actually have an impact on shape. And bone shape is known in osteoarthritis to affect pain. So there are multiple things that are sort of linked together when you use an AI model, and you might be including some of these features, but clearly the generalizability across populations, it has to be established, it has to be tested. But that was true even for the grading systems. In yesterday's talk, you heard about the issue of Kellgren-Lawrence scale, which was done in England several years ago, and now how does it apply to a African American population and so on? So these are the questions which exist and really need assessing.
Okay, here's a challenging question. Let's see if are there concerns that these predictive tools may be misused for discriminations, for instance, denial of health insurance for pre-existing conditions? She says, I don't know if Sharmila has the answer, but what are her thoughts?
Responsible AI, you have the institute in Santa Barbara, something that you guys should really take up. How are these going to be interpreted? It's not just for denial of health insurance. Imagine if you're a basketball player. Imagine if you're a basketball player and you have some lesions, and I say within catastrophically that this kid at age 18 has I'm predicting will have a knee replacement in 3 years' time, will need it. Then it could have a terrible impact in terms of people's lives, careers, certainly denial of health insurance. And I think this is where the ethics of using AI, the ethics of any advanced medicine, though. I mean, what about it's the same thing that genetics is basically dealing with in terms of how it will be used, and knowing you've done 23andMe and you're a high risk for stroke. How is the health insurance companies going to be using that? I think the issues are very similar with AI. I don't have the answer. You're quite right. What are my thoughts on it? I think that from my perspective, how this tool is used in practice for patient guidance, for decision making, etc., will depend on how our patients want them to be used for their treatment. And I think it is the consumer. I think that's where we need to start asking people. And that's going to depend on the socioeconomic status of the individual and the area you're in, and so many different things. This is why I said, the gray box for the clinical deployment is an open question. But now you're asking for the societal use. That really is, completely an open question. But that is a question that's has been opened up with genomics and other advanced medicine as well. So I'm pretty sure responsibly we can do it together.
Thanks. That was a challenging question. Great answer. Here's another one. In the future, if you incorporate AI into the workflow for training novice radiologists, do you predict that they will be heavily reliant on this AI's prognosis for decision making? Can this have negative consequences?
Yes and no. Yes, they might be better radiologists in the sense they would be more systematic in terms of the agreement between different radiologists. They might be faster, but you understand, a radiologist who gets dependent on AI for decision making is literally like asking whether somebody is dependent today on their cell phone. It is led to a lot of, yes, you see people with their faces stuck to the cell phone and they don't have conversations. We all talk about those things, but it's also brought forward several improvements. It's brought forward the fact that you can actually be monitored for irregular heartbeats. You can, it has some positives as well as some negatives associated with it. So my feeling is anybody who is an elite radiologist or a trainee or not, any radiologist you've gone through to go through medical school, you will find other ways of using your information, doing a more comprehensive assessment of your patients. You'll just become a better doctor. The radiologist will go beyond providing just the information about the image. They will become an absolute important cog in the wheel of a person's evolution in their medical history, I think.
Great. And here's one. I think we still have time for a few questions. Here's one that I've been thinking about. Based on the last part of your talk having to do with pain, I'm just thinking, how do you think having something like an AI or a deep learning algorithm predicting pain, how is that going to impact how the doctor balances sort of the judgment they make based on what's a problem with the knee, what's going on with the cartilage, based on sort of these measures of pain? Is that going to impact, you think, the weighting to these two factors in deciding on the treatment? Clearly now they have a patient and they measure how much pain they have. But do you think is there going to be a more pain focused sort of decision making for treatment, or you think that's going to be unaltered?
Decision making for treatment in any disease is, of course, it's modulated by pain and disease severity, but there are other unseen factors, right? It's access to healthcare, it's cultural biases, it's funding and money, how much money, what socioeconomic status, can you afford a total knee replacement or not? And cultural biases play a very significant role in this kind of decision making. So pain will certainly be a certain outcome. Perhaps what it will do best is, have you ever done a pain questionnaire? Depending on how my morning is gone, my pain can be severe or moderate. Depending on how long the questionnaire is, I get irritated and answer whatever I feel like. And I'm a motivated volunteer in my own research studies, and I'm literally telling you this. So can you imagine all the coordinators who are trying to make me do the questionnaires, and I tell them, God, this is so boring, I don't want to do it. So pain being so subjective, so dependent on the day-to-day, I think perhaps the only way, if you could predict pain in a objective way or have a pain predictor in some way, then it provides the physician with at least saying that, God, this may be the reason, and this might be the reason for the pain, or this person is really neurotic, is a hypochondriac, and always over amplifies pain. So I think it might assist in that, because I have seen people who have bone on bone and no cartilage and osteoarthritis and have no pain, and others who have absolutely the cartilage is intact, perhaps their T2 values are high, and they're saying, oh my God, I'm dying of pain. Now, is that perception? Is that reality? Are there other confounding factors? Maybe it'll pick out some of the other confounding factors. Yesterday, this question came up. Could it be that there's a hip pain and a knee pain, and it's the hip pain that people are really focusing on, and are also saying my knee also hurts because I walk weird, because my knee is really my hip is misaligned? So I think it'll unravel a lot of these things, especially if we can mix it up with sensor data, biomechanics data, which these days you can actually measure with your iPhone. So I think it really opens the field up completely.
Thank you. We have a bunch of other questions that came in. Since AI assessment will not be always correct, what would be necessary for a radiologist to trust the AI tool so that they can incorporate the AI assessment appropriately?
So firstly, we need to do, as I said, some kind of generalizable studies across populations. So if it has to, you have to know that this works in your population. There have to be some outcome studies looking at these things in detail. Secondly, there have to be some outcome studies that does this actually ultimately, what are the features that will ultimately affect patient care and patient progression and so on and so forth. And a radiologist is always at will to decide whether or not they want to trust the AI tool, right? So most of the AI tools that I'm thinking, I mean, for FDA to actually accept an AI assisted tool as a diagnostic, it's going to take an enormous amount of legwork. But if it's decision support and it enables and makes life easier and faster, that could be a different issue. And so it really depends on the radiologist, their mindset, and how they emerge. Again, here there will be cultural issues, but outcome studies are essential in this area.
Great. Here's another one about pain. We're back to, do you think pain has relation to implant design? So I imagine that's the having to do with the knee replacement, and how does the implant affect pain? And does your model count implant types for outcome prediction?
Most of all of our studies have been done with patients without implants, just to let you know, because with implants, analysis of the MR images becomes really difficult with the presence of the artifacts that occur in MR images as a result of implants. So these are not actually in patients, and we haven't considered anything about implant design. But there are several factors which affect implant design and therefore could affect pain in the long run. For example, shape of the bone is related to race and gender and various other factors, and the shape of the bone and thus the shape of the implant and precise design of the implant plays a significant role in. And there are efforts to do individual precision developed implants and so on and so forth. So therein, I think there could have some impact. All knees are not identical and so on and so forth. So there is an impact on pain. How implant design affects pain generally over the long term in terms of osteoarthritis, I haven't done any systematic studies, as I said, primarily because we haven't looked at patients post implant in many of our studies. So it's not a very satisfactory answer, I know. But I also want to let you know that, again, implant design does play a role, and that can be modulated by structural features, which are dependent on so many different things.
And the questions, as we've been seeing over the last day, the questions get harder and harder. It's like they get more people.
It's okay.
To what extent can you model the psychological and mental state of the patient as part of the decision making and risk assessment of different options? I have a feeling this was a this came from your observation, that what if this person just is a hypochondriac and is like thinking about pain all the time, and I guess that's where this question came from, but it's a good one.
As the questions get harder, my answers get more sort of big vision, focusing on the future and totally hand wavy, but that's what I'm going to do right now. But think about this. Imagine if you could do knee imaging really quickly. Within 10 minutes, you've got everything you need, including shape, including all these features, factors, everything. Then you spend 10 minutes doing brain MRI. You have figured out, with using fMRI and maybe resting state MRI, all of the connectivities within the brain, which characterizes the hypochondriac, the sources, are the localized sources of pain really lighting up to the extent they should be based on the patient reported outcomes, etc. If this were possible, if it were possible to do psychological brain imaging with all of these things included, as well as knee imaging, imagine the connectivity or the huge total body connectome you're building up. You're really going to get to the truth. So I think it's wide open. I think we could do this. A lot of times in many of these studies, people have, pain catastrophizing questionnaires, many psychological mental state questionnaires. They're all questionnaires. I'm saying, okay, you can do that, but let's go beyond that. Let's get fMRI to the point that we can actually include all these different features. Then we're there.
Okay, fantastic. Okay, I think we've now we've actually exceeded a little bit our time, but this is good. There are great questions. I want to thank Professor Manjudar. Thank you very much for joining us. Thanks the audience for all those questions. And we will now move on to the session. Let me share my screen. Okay, so I think some of those topics and themes that we had in the questions are going to be addressed, or we're going to, at least we're going to have work presented that's very related to some of those themes that we were talking about. So in this session, we were going to have 3 talks. The first one will have to do with breast screening. Ioannis Socharopoulos from Radboud University will be talking about breast screening in Europe. Now, for those of you not familiar with breast screening, why is the word in Europe mentioned there? Is because different countries have come with through the history with very different solutions to breast screening. So we're going to get an update of what is the solutions that are sort of being thought for Europe. After that, we will, Shamim Namati from UC San Diego, we will tell us about machine intelligence in critical care, where the stakes are higher, where you have to make decisions, the time is a little bit reduced. So, so it's very critical to understand and interpret the AI advice and also trust it in order to make a decision. And then in our final talk, we will, Carl Myers from the FDA will tell us about the role of the Food and Drug Administration as AI developments start piling up and skyrocket. What is the role of the FDA in trying to support these developments and also trying to evaluate them and provide sort of procedures to evaluate and regulate the different solutions. Now, just to give you a little bit of a just to give you a little bit of some information of why there's still a lot to do in this area. There was a recent survey from the Journal of the College of Radiology. That was a survey this year. It was a survey of about 1,800 radiologists. And of those, 33 of all those 1,800, 33% of them are currently using AI. More of half of all radiologists said that they see no benefit in using AI, which is worrisome. And the vast majority, 94%, find its performance in clinical practice inconsistent. So that just sort of highlights where we're at in trying to convince radiologists that AI will be useful and it will be helpful for them. So with that, I want to invite our first speaker to join to share their screen. Ioannis will be talking about AI for breast cancer screening in Europe, possibilities and current results.
Thank you, Miguel. Good morning, I guess, for you. Thanks for the invitation to give this talk. I think now you can see my screen, correct? I guess somebody will shout if you can't. So
yes.
Okay, great. So yes, my talk is about AI for breast cancer screening in Europe, and I'm going to describe why we point out Europe, not only because I live here, and do a little soul searching and looking at the future or potential future. So, when we talk about introducing AI for breast cancer screening here in Europe, and probably this is true for radiology and probably true for anywhere in the world, is we don't exactly are sure where we're going to end up and how we're going to get there. The path is probably complicated, and to be honest, we don't really know even if we should. Right now, we don't have the evidence to say we should definitely take it up. And I think that result that Miguel just mentioned, I think it's quite interesting. Clearly shows that we still have a lot of work to do about, especially which is the best way, once we get the right AI, which is the best way to implement it, especially in something as screening throughout Europe. So I'm going to give a little bit of a overview of what screening in the Netherlands and in Europe looks like right now, and then where we think we might end up and how we could decide to get there. So these are my disclosures. I do work closely with many companies, some of them that do AI, but I don't have any financial interest in them. So screening in Europe is breast cancer screening in Europe is quite different from how it is done in the US. First of all, for the most part, it's population-based screening is usually a program run either by the region or by the whole national government. So it is very homogeneous, and it's also very high in volume, speed, and high in speed, and very controlled in terms of performance metrics. In most countries, if not all, where they have a screening program, all mammograms are double read. Of course, in the US, this is for the most part, I don't know of any institution that double reads their screening mammograms. And I did say mammograms here in Europe. There is no uptake of breast tomosynthesis yet at the screening program level. Well, that's obviously not true in the US. Mammography as a screening technology is pretty much not used anymore in the US. But here we still haven't moved towards tomosynthesis because of the lack of evidence, let's say, of the medium-term outcomes, and also for different reasons I'm going to mention in a few minutes. So if we focus on directly on the Netherlands, to give you some statistics of the performance of screening here, and these are not necessarily representative of all of Europe. We do pretty well, I should say, but it gives you an idea of how different the performance metrics are with the US. So, for example, the referral rate, or what we call in the US the recall rate, is just 2.4%. In the US, guidelines say that it should be around 10%, and with tomosynthesis, it has gone down a bit, quite a bit, but still quite higher than this 2.4% that is here in the Netherlands. At the same time, the cancer detection rate is almost 7 per 1,000, which is quite high. And the size, which is important, the size of the lesions is actually also comparable to the distribution found in the US. So performance is quite good. But of course, it's not perfect. If we look at the interval cancer rate, here the program is, the screening is done every 2 years. So the interval cancer rate is based on a 2-year period. It is 2.2 per 1,000. So 1 out of 4 diagnosed breast cancer in the screening population are diagnosed outside of screening. And in retroactive looking at mammograms from screening that where interval cancer was found, it was deemed that 50% of them are visible. So they were actually there on the day of the screen. And of course, with a 2.4% recall rate and 6.8 per 1,000 cancer detection rate, you can quickly work out the math that for every cancer case that's recalled, we also recall 2 healthy women. So that's pretty good compared to many other countries, but it's still far from perfect. So of course, there is an interest in improving things with AI, and well, some of the questions is, well, for example, why now? Well, one key feature of hope of AI is to solve the issue that we are actually running out of screening radiologists, and this is true in many countries throughout Europe, especially in Sweden and the UK. But here, it's also going to become an issue. Large percentage of radiologists, of screening radiologists, are retiring at a rate that we're not replacing them. There's especially compounded by the fact that if we want to move to tomosynthesis, well, tomosynthesis just takes longer to read. So right now, we don't have the resources to add this doubling of time of reading of tomo exams. Imagine that combined with having fewer and fewer radiologists to do the reading, and there's a problem that needs to be solved somehow if we want to move to tomosynthesis. But also another thing that I think is really interesting and makes some kind of computer-aided detection aid for screening is that if you look at some results of some tomosynthesis studies across Europe, is that usually what you see here is usually true in many of them, that DBT did not have, especially if they go back and look at false negative cases, the lesions were actually visible on the tomo image, all of them. Usually the false negatives, if there were any, were misinterpretation by the radiologist, not that just the image did not show the lesion. There's another study from the group in Malmo in Sweden. They actually went back and looked from an ROC study in which they compared DBT and mammo. They looked at all the false negatives in tomosynthesis. And of course, there were fewer false negatives for tomo than mammography. We expected that. But also the interesting thing is, as I show you here, is that all of them, well, most of them, 6 out of 7, were actually interpretation error. So the data was actually there. So we just need to do a better job finding it. And that's where the AI comes in. If the technology, the imaging technology, is just not good enough to show you the lesion, then the AI can be fantastic. But if there's no sign of cancer, then it will never find it. And of course, why now? Because, well, now deep learning over the last 6 years or so has come into the picture, and of course, its performance seems to be kind of magic. So there is a renewed interest in what it can do in screening for breast cancer. And a typical AI-based, this is a commercial product for detection of breast cancer in mammograms and tomo images, I should say. And a typical product like this one can highlight a lesion that it found and give you a percentage probability of malignancy for that lesion. But I can also see, you can see on the bottom right, this number 10. This is a probability of malignancy for the whole case, and the rating goes for this software from 1 to 10. So the AI can also work standalone and not only show the radiologist the suspect lesion. So how good are these algorithms these days? Well, there's many studies evaluating their performance. I'm going to just mention 2. One of them is, we actually performed it here, in which we compared the performance of the AI system to a large number of breast screening radiologists. And what we did is, instead of go out and perform a lot of observer studies with many radiologists, many cases, we actually reached out to a bunch of our friends from here, Europe, and from the US. And we asked them, we looked at sets of studies that have already been published, in which usually people did an ROC study comparing tomo to mammography to something else, and the something else these days is always tomosynthesis. So we asked them to share their mammography images and all their human reader results for all the mammo images that were included in the study. We ended up with 9 studies. The data sets came from, as I said, multiple countries in Europe, and 2 of the data sets were in the US, and the data was actually read by pretty much 50-50 split of radiologists in both sides of the ocean. So we had a quite variable data set and reading. The radiologists were also very variable in terms of experience, from really recent entry into screening breast screening, and also all the way up to 45 years of experience with screening. And as I said, from both sides of the ocean. And we ended up collecting 2,600 mammograms, of which 650 were malignant. So a pretty, of course, enriched data set, like is typical for ROC studies. And the final number of radiologists we collected across all these case studies were 101, which seems like a good number to stop collecting. So overall, there were over 28,000 independent interpretations. Of course, not all 101 radiologists read all 2,800 mammograms, since they were from different data sets. And the mammograms were acquired from the 4 major mammography vendors. So again, we had quite a bit of variability across data sets. The system we evaluated, the AI system we tested for this, was the Transpire from ScreenPoint, which you might have read in my disclosure. It is a spin-off company from my department, but I'm not involved in the company at all. And if you look to the results, we do see that the AI system we found was non-inferior to the 101 radiologists in terms of area under the curve. If we compared individually each radiologist to the AI system did outperform 60% of the radiologists. But interestingly enough, the best radiologist of each of the individual 9 data sets was better than the AI. So there was, at least a couple of years ago, room for improvement. Radiologists were better than the AI software. Since we published this, of course, the AI has continued to improve, and the software has gone through 2 or 3 more software versions, and we have rerun the images through the newer versions, and we see the AI has continuously continued to improve in terms of performance. So it's interesting to see that this thing just keeps getting better and better. There's, as I mentioned, there are many other studies. I'm not going to mention all of them for the sake of time, but the message is pretty much the same. This one I do want to mention because it's tomosynthesis and not mammography, and this is from UPenn, in which Dr. Conan compared the performance of 24 breast radiologists evaluating 260 cases in a standard ROC study, and you can see the AI performance goes right through the cloud of dots or discs of the readers. So again, pretty much equivalent performance to the average reader, but there are readers that are better than the AI. This 2 studies, just like most of them, they're all multi-reader, multi-case ROC studies. So they have well, first of all, as I mentioned, enriched data sets and a laboratory effect, and some of the data sets that we included in our study didn't include any priors. So there is a bunch of limitations. These are all, let's say, laboratory tests, but it seems like we are on our way, that AI does do pretty well, but we cannot say this is the final evidence that AI is at the par or even better than radiologists in the real screening world just yet. But okay, we seem to be getting there now. The question is, what do we want to use it for? And of course, one thing is, well, maybe, as I said, tomosynthesis takes too long. We're running out of radiologists. Can we just go faster? So the study that I showed from Dr. Conant, this one, it did look at that, does using DBT AI, to assist the reading of the tomo slices help radiologists go faster? And the answer is yes. Navigating using the AI for navigation aid does substantially speed up reading. In essence, it halves it, which is great. This does open up the idea, at least in my point of view, that now we're not doing AI-assisted radiologist reading anymore. We're more kind of doing radiology-assisted AI reading, because with a 50% reduction in reading time, the radiologist is not doing the search across stacks. It's mostly following where the AI is taking him or her. So we have to, I believe, be aware of that. Of course, we don't only want to do faster, we want to do better. And this is also appears to be the case. Same study, DBT plus AI, and Dr. Conan showed slight but significant improvement in the area under the curve. So that's also encouraging. If you look at the per reader performance, these are the discs of each individual reader without the AI. And if I move to the discs, the performance of the readers with the AI, you can see mostly they all move to the top and the left, which means they do better. And the size of the discs is the reading time, and they all get smaller and they all get bunched up closer together, which means they become more consistent across readers. So in essence, everything goes in the right direction. In terms of, well, does it matter in medium-term outcomes? Well, there's a study from again from Malmo, from Sweden, showing that, well, if they looked at interval cancers and ran them by the AI and saw, okay, how many of these interval cancers were actually marked as a very high risk score, and they did find that of all the interval cancers and therefore cancers that were missed, about 20% could have been detected if the reader, this is a simulation study, of course, so they don't actually know what the reader would have done, but if the cancer was minimally or not at all visible to a reader, but the AI pointed it out with the highest risk score, and of course the AI found the right place, then about 20% of all interval cancers could have been pointed out by the AI, and without increasing the recall to a crazy number. But of course, the holy grail is not so much assisted reading, but is standalone AI, right? So we want to do less and better at the same time, not just necessarily faster. So we want to move from assisted reading to, as I mentioned, standalone AI. And the idea, in essence, is mostly we have this group of screening cases. To give you an idea, here in the Netherlands, the screening program is nationwide. We acquire 1 million mammograms a year. And now all of them are double read no matter what. So the hope is, well, if we first read these mammograms in some way by the AI, and the AI gives us some kind of score and decides who is going to read which cases. So is it going to be, do we need any human to read this case, or just one reader, or two? So we've done some studies about this, and for example, one idea is, well, if this is the distribution of AI scores across a screening population, you do expect, at least this software is normalized to give you an equal number of cases in each probability of malignancy score for a whole screening data set. So you do expect a distribution like this one. And of course, for the cancers on the right, you do hope that most of the cancers are the highest score possible. And this is on the data set that I showed about the 101 radiologists versus AI. So the idea is, of course, we draw a line and we say, well, anything scored 5 or below, we just say this is normal and no human reads it. How many cancers would we miss? And of course, we would miss those the small bars on the right graph to the left of the red line. And if we don't want to miss that many, we can move that threshold to, let's say, score of 2 or less. Nobody reads those. And what would happen is, of course, we would read about half of the cases we do read now. We would miss about 7% of cancers, but we also reduce the number of false positive recalls substantially because of the recalls of cases that were normal and were scored low by the AI. 7% of cancers might be too high a number, even though radiologists do miss, as we said, about 50%, but still, we hold the machines to a higher standard. So maybe we need to be more conservative and say, okay, we reduce to the level of the score of 2, and that gives us 20% of cancer reduction, while we lose only 1% of cancers. The truth is, whichever score we select to do the threshold, we found that the performance itself will be the same, except for the highest threshold at 9. And it's just a question of where do you want to operate on the curve, how many cancers you would miss versus recalls, false positive recalls you would not recall. Similar study, again, from Mamo, showed that, if you did, well, the very low scores nobody reads, but this in between scores, in this case 3 to 5, one reader reads that many, and for the rest you have 2 readers. Then you could have only 7 cancers, not that they're missed, but they're read by only one radiologist, and then it's up to him or her to find those cancers, and you would have a 20% reduction in total read. And 10%, 5% reduction in false positives. So something like this. The interesting thing is, of the 7 cancers that AI said these are those in-between scores 3 to 6, 6 were clearly visible. So it seems like we only need to improve the AI to some degree, and maybe we can make the AI really find these cancers that it's missing today. But of course, there's a percentage of cases that nobody will read. Some cancers will be missed, and perhaps people will not be that happy when we tell them that the software missed your cancer because no human ever read this mammogram. So one option to get around that is to say, okay, we do double reading. Let's have the AI, the standalone AI, be one of the 2 readers. So the current format for double reading in Europe, or in most of Europe and the Netherlands for sure, is the one on the left. 2 readers read independently, and when they disagree, a 3rd reader becomes the final decision maker. Our scenario is, well, the 2nd reader is in an AI, and if the AI and the 1st reader disagrees, a 3rd reader, which happens to be a 2nd human, makes the final decision. We ran this simulation using the same 9-set data set that I already talked about. And of course, the the workload reduction would be substantial. It would be around 44% fewer cases read by humans. That 6% is because, of course, the arbiter needing to step in. The sensitivity would be the same, so we wouldn't miss any cancers, but the specificity now would be higher. So this was a bit surprising at the beginning when we got these results, and then we started thinking about it. And this is the theory I have. To me, yes, the AI performs as well as a radiologist, but I think the AI detected cancers that the other reader didn't find was equivalent to the second reader, let's say, but the false positives of the AI are actually easy false positives for a human to discard. So it contributes the cancers that a second reader contributes, but the third reader can discard easily the mistakes that the AI makes. And another very interesting study that just came out a couple of weeks ago in radiology gives a very good idea of how might Europe perhaps move to DBT screening, in which we go from double reading of mammography without AI to this sort of scenario. No human reading for low scores of low AI scores of DBT, double reading of the top 30% most suspicious plus of the added AI-based ones. And you can see the workload in terms of number of hours read went down by 30%. Remember, Tomo takes longer to read, so this actually solves that question easily, and the sensitivity goes up and the recall rate goes down, so all go in the right direction. So AI for breast cancer screening in Europe, we can summarize it and say, well, the lab results for now do show that we do better and we could reduce the number of interval cancers we miss, but we do need prospective screening trials with cases at the prevalence level. It seems that we could go faster when AI is assisting readers, and there are multiple strategies to try to do less. We just have to find the right balance between cancers missed and improving in the imaging technology to use. All promising results. We do need more. As I said, we do need prospective trials. And for that, we can reach out to the MSI people to help us out. And I mentioned them because there actually is one prospective trial with AI in screening going on right now in Malmo headed by Dr. Lang, and she called this trial the Masai prospective trial. And she's randomly assigning AI or no AI to screening on 100,000 women. So we're very excited to look at those results when they're come out. Of course, the evidence that we still need to generate is, of course, which cancers does AI-based screening find? Is it the same ones? It's not a question only about numbers, but also the dangerous cancers are the ones that we need to find. And other thing that we cannot capture with all these retrospective studies is how will the reader behave if he or she knows that the AI pre-selected the cases that the reader is reading. And of course, when I asked the 159 radiologists this question, they all recognize that, well, not all, but many recognize that they wouldn't read the same way. And that is something that we need to investigate further. How does pre-selection or any of this AI addition affect their performance? Should the reader know why they're reading this case? What did the AI think? Most radiologists seem to think, yes, I want to know when you show me an image why the AI thinks I should be reading it. Very few others seem to think like, okay, I want to read the case first. And one thing that I do think we need to discuss is how much more evidence do we need? I'm not saying we have it now, but where do we stop in terms of before we introduce AI for screening? We let anybody drive a car these days. But as soon as it's an AI that is driving the car, then the threshold of is that acceptable or not becomes much, much higher. We also, if I asked any of you who made your MMR vaccine that you got when you were a baby, probably your parents have no idea. And these days, we want to know who made the vaccine, where was it made, and what is the percentage of effectiveness and all that. So again, we're perhaps hypersensitive in some aspects. And like Jeremy Wolf told me a couple of years ago, when you do a blood test, nobody's counting, no human is counting the red blood cells in your blood. It's just put into a machine and the machine comes out with a result, and we don't question that either. So we have to, I think, discuss where does the requirement of evidence end. It was encouraging to see that for most radiologists, AI, at least for breast cancer screening, seems to be now an opportunity rather than hype or a threat. So thank you very much for your attention. And again, thank you for the opportunity to present today.
Thanks very much, Ioannis. We have a few minutes maybe for one or two questions, and then we will have time at the end to ask more questions. So go ahead in the Q&A. Let's see. Thanks for your, you mentioned using the threshold based on risk assessment to decide how many readers would be needed. Should we also think about having a threshold based on an AI that says how hard each case is to read, and then have the human readers or more human readers only in the harder cases?
So maybe that was somebody is aware of some of our work. So we actually have a project going on that I didn't want to mention because I can't mention everything. That so it's that we think if a radiologist should read this case, and if they should, how many radiologists should read this case, should be based not only on the probability of malignancy score by the AI, but also how certain or uncertain the AI is about its score. Because if it's very low but very high uncertainty, then a radiologist should still read it. And then we are trying to develop also a human case reading difficulty score to decide if it should be one reader or not. So I definitely agree with the proposal.
We have a pretty fascinating second question, but I think it's going to lead to a lot of interesting debate. So I'm going to reserve that second question for our Q&A at the end. So with that, thanks very much. And we will move to the next talk by Shamim Namati, Biomedical Informatics, UC San Diego, Machine Intelligence in Critical Care, Role of Interpretability and Trust.
All right. Okay, thank you very much for inviting me here today. So I'm an assistant professor of biomedical informatics at UC San Diego. I'm also the director of predictive health analytics at our hospital, and I sit on our sepsis committee as well as our AI committee. So today I would like to talk about machine learning and its applications in critical care, and focus on two topics. One of them is model interpretability, and the second one is sort of barriers to trust and adoption of this type of tools. I have no financial conflicts of interest to disclose. I do have an intellectual disclosure, which is I'm not an expert in trust or interpretability, but I have plenty of friends on Twitter who are. So that gives me enough of courage to talk about this topic today. All right, moving forward. So a lot of my work over the past 10 years has been focused on intensive care and looking at application of machine learning to early prediction of various events. One of the area of focus has been sepsis. As you may know, sepsis is a condition involves the dysregulated immune system response to infection, which, if it goes untreated, may result in end organ damage and ultimately death. Sepsis is a big problem worldwide. Around 48.9 million people every year get sepsis. Mortality is very high. Within the United States, we have 1.7 million cases of sepsis every year, and 270,000 Americans, they die of sepsis. If you look at the cost, it's also very, very expensive. If you just look at the cost for Medicare recipients, is about 20 billion, and this data is from 2011. I looked up the numbers for the past couple of years. This number actually is more closer to 45 billion now. And there are a number of conditions like that, like acute kidney injury, what we call AKI, that also have very high prevalence and high death rate. In the case of AKI, we have 100,000 cases. And a common theme here is that it's believed that if you can catch these conditions early and give patients the right medications, or in some cases, if you could withdraw the wrong medications, like the ones that are nephrotoxic, then you could actually save lives. So in case of sepsis, we specifically know from some retrospective analysis that if you could catch sepsis early, you could save lives. The number is every hour treatment of sepsis while antibiotics is delayed, mortality increases by 4 to 8%. And this is a motivation for why you may want to look into predictive analytics and look at all the data from bedside devices, from different sources that are organized in electronic health record to make predictions. As Miguel mentioned earlier on, here we are talking about predictions at very short time horizons, around 4 to 8 hours. Another way to think about this is the analogy of a healthy home, and then you have a little bit of smoke coming out, and when you see the early signs of smoke, you don't really know if it is due to a cooking accident or it's actually a fire. And so you want to figure that out, and you want to come up with the right intervention to avoid full-blown fire and ultimately death. Some people say, why don't you put just everybody on treatment or antibiotics? This is analogous to saying that, why don't you just call the firemen on every house that has a little fire coming out, which is unrealistic. We know that every treatment has adverse events or outcome associated with them. So we want to be very judicious in our use of treatments. Okay, so like many of the speakers on this conference, over the past 10 years, my team has been working on developing AI systems. Here's a paper in 2018 published in Critical Care Medicine that we claim that using an interpretable machine learning algorithm, we can predict sepsis ahead of time, 4 to 6 hours in advance with an AUC of 0.85. And what you see on this image is a timeline of a patient, 72 hours or so. Every dot here is 1 hour. And sometime around here, clinician recognized that this patient was showing signs of sepsis, so they ordered antibiotics and cultures. The algorithm that we developed was able to cross our detection threshold several hours in advance and providing enough of advance notice to clinicians to examine the patient for themselves and if necessary, put the patient on antibiotics. But this was also one of the, I could claim that was one of the first papers with the title of interpretable blog, that was published. And what we have done is we basically look at relevance scores at the time, and we said, can you tell me that every point in time, what are the top predictors? And it's a little bit hard to see, but the algorithm says at this point in time is temperature and heart rate, and the fact that this patient had surgery with open wounds. By the time we came to the time of clinical recognition of sepsis, there are evidence of organ failure. Things like creatinine is abnormal or lactate is abnormal. Your end organs are doing what is called anaerobic metabolism, and those are the early signs of organ failure. So again, the idea is that if you could detect sepsis earlier on here, you could put patients on antibiotics and maybe stop the patient from transitioning to organ failure and potentially death. Again, like everybody else, we had our second and third paper with application of deep learning algorithms, and we have shown that deep learning algorithms, they really do better in terms of AUC and other machine learning focused metrics than all the other competing methods. All right, so we moved on to receive a $1 million grant from BARDA, stands for Biomedical Advanced Research and Development Authority, to look at multi-center validation of this algorithm and do an implementation study on the cloud, and then prospectively implement the algorithm at different sites, and then finally seek de novo FDA approval. So as a part of that effort, we looked at how we can get data in real time in a live critical care setting. This really required talking to different devices, talking to electronic health records. We actually decided to go one layer below the network and ask the question, where are the epics and centers of the world are getting their data? So we had to teach ourselves HL7 protocol, and we managed to get that data without actually directly going to the electronic medical records. And we created the environment on our HIPAA compliant AWS that integrates this data and organizes data. We made it to be FHIR compatible, and we use that information to make predictions in an interoperable and scalable fashion. So here is sort of a description of the software pipeline that for portability, we made it containerized. And for HIPAA compliance, we had to create audit logs, etc. And then here's this very simple user interface that we came up with back in 2016, 17, showing that here is a sorted list of patients. Each of these little panels show one patient, and the patients are sorted according to their list for sepsis. And moreover, because the claim was that the algorithm is interpretable, so we said maybe we can incorporate some of this information into the user interface. So we were inspired by the gamers. If you click on one of these panels, it flips over, and in the backside, it shows the top causes for why the algorithm thinks the patient is septic. Okay, so with that little introduction, I wanted to jump into this issue of interpretability, and talk about two topics. One of them is opening up the black box of deep learning, and some of the things that at least for us was a little bit counterintuitive, and then going beyond pattern recognition to decision making, and see how that complicates interpretability of these algorithms. Okay, so most of you should be familiar with these ideas of relevancy scores or SHAP values, and there are ways to open up the machine learning algorithms that ask the question, what are the top predictors of sepsis or AKI or whatever is your outcomes of interest. So in this case, it turns out here is 10 hours to the onset time of sepsis. And the algorithm is saying that in most of our patients, heart rate and temperatures are associated, an increase in heart rate and temperature are associated with sepsis. There are white blood counts, there are other factors that are showing up here. But we wanted to do a little more than just global analysis of what are the top factors. So we asked the question, what if we mask the globally most important factors? What happens to the performance of the algorithm? We just set them equal to missing. Next, we asked the question, what happens if you mask the locally most important factors? And here is basically the results when this is the performance of the algorithm in terms of sensitivity, specificity, and AUC. And once we masked all the globally important factors, we noticed that actually really very little actually changed in the performance of the model. Versus when we asked the question, if I replace the most important factors at this point in time for this patient, what happens? We notice that depending on whether we are masking factors that are increasing the score or masking the factors that are decreasing the score, we see a huge drop in sensitivity or specificity of the algorithm. So this basically showed to us that when you are dealing with deep learning algorithms that they look at interactions and temporal patterns in the data, really the explanation or interpretability is very local to this patient at this point of time, because the algorithm is really paying attention to contextual information. Okay, having said that, when we presented these results to our clinicians, they said, cool, okay, let me know what I should do. What is really actionable here? And this made us start, thinking about this notion of organization of knowledge, how clinical knowledge is organized. I love this paper from Vilma Patel. Is talking about cognitive approaches to clinical data management. She basically says that clinical knowledge is organized in multiple hierarchies. At the very low level, you have these basic clinical concepts, things like your clinical measurements of heart rate, blood pressure, lactate, creatinine, etc. And then you have findings. If your heart rate is above some threshold, then you say that this patient is experiencing tachycardia. And then you have clinical constructs. If you see tachycardia and if you see also high temperature and abnormal, let's say white blood count, you might say that this patient has the Sears criteria, the systemic inflammatory response. And then at the higher level, you have this diagnostic hypothesis. So again, here's the example. In the case of sepsis, these are some of the immediate findings. And then you combine those findings, you come up with constructs like Sears and then you combine this construct with some other contextual information, you come up with a diagnostic hypothesis. And as we all know that diagnosis in medicine has also a high level of uncertainty. And then you have some system level explanations. So one of the things we started thinking about was that maybe the explanations we are providing to clinicians are really not at the right conceptual level. And this is, I believe, where most of the machine learning literature is stuck. Here are the raw data, and then we provide explanation at the level of raw data. So here is a bit of sort of food for thought that maybe we should actually think about at what level of abstraction information is useful to clinicians, and the explanation that we are providing to clinicians, maybe it should be at the right level of abstraction. So with that, we started looking into literature and talking to our clinicians, and there's a number of things that actually came up. One of them is providing explanation should be at actionable conceptual level. The second one is that clinicians, they have access to very rich contextual set of information that are missing from existing AI systems. Just here's one example from the world of sepsis. It turns out if you're showing signs of dysregulated host response to infection or this sort of inflammatory response, it really matters whether the patient had surgery or not, or whether this is a patient that is very old or not, because like in old patients, their immune system might be actually suppressed and they may not show the inflammatory response. Similarly, post-surgery, patients are showing abnormal signs of inflammatory response, but it has nothing to do with infection. So knowing about context is very, very important. In fact, if you listen to clinicians, especially like ED clinicians, they tell you that history is the king. And that brings me to this notion of a lot of our EHR-based AI, they go through this process of variable selection, and you come up with a very parsimonious model. And based on that, you make a prediction. And typically these type of systems, most existing systems, because of that sort of first step, you're missing a lot of this contextual historical information about the patients. You also have this type of sort of web-based calculators that are popular. Like in the case of COVID, you could go in and you could type in the symptoms of the patient and you could say, what are the chances of this patient to be hospitalized? So I like to advocate that, even though we typically start with EHR-based AI systems, we need to have a type of dialogue with clinicians through maybe other types of interfaces that we can, through those dialogues, we could bring in some of that historical information, contextual information to really narrow down the use case and reduce our false alarms and make more accurate predictions. The next topic is that really the notion of interpretability depends on clinical context. In my world, I work with emergency doctors, with intensive care unit doctors, and in some cases with telemedicine doctors. They all have their own objectives. In emergency department, you want to very quickly move patients to the next stage. If this is a critically ill patient, you think it's going to crash, you want to move them to ICU. Within the ICU, you are thinking about something else. You want to stabilize patient, you want to treat them. If you're looking at in a tele-ICU setting, objective here is to advise and provide a second pair of eyes. And really depending on the context, you may or you may not care about interpretability, and you may actually look for different types of clues. Here is a publication that I came across and I just highly recommend to everybody to read. This is by Hannah Wallach's group from Microsoft Research. She looked at, looking at interpretability in a very different context. But one of the conclusions that they made in the paper is that users of AI, they prefer completeness of explanation over soundness of explanation. They want to see a very complete picture. And she used the term of broken leg problem. This is the classic example where you have an AI algorithm that is able to predict when Jack goes to see a movie. And the AI algorithm does a very, very good job, but it just doesn't know that Jack has a broken leg and cannot go to see a movie this week. So this is known as a broken leg problem. We see that problem quite often in AI. Again, in my world, I sometimes predict sepsis, And the clinician says, well, this is a bone marrow transplant patient and might look like a septic patient, but the patient is not septic. Just the fact that my algorithm didn't have access to that one piece of information somewhat discredited the algorithm in the eye of the clinicians. So it's very important to provide complete explanations. So I wanted to briefly connect this to this idea of knowledge graphs. I believe that there is a lot of opportunities at the intersection of interpretability and knowledge graphs. This is a very nice work from David Sontag's group at MIT. They basically said, some of these higher level explanations that we might be looking for, you are probably included in clinical notes. And why don't we go in and construct a knowledge graph that looks at disease and symptoms? And let's say, in the case of sepsis, you could look at what are the things that the clinicians are looking for. And, there are ways to extend this work. And I personally believe that, just disease and symptoms are not enough. You need to look at historical information, more contextual information. So your knowledge graph has to be a little more involved. But I think these are really going in the right direction if we broaden our scope and don't focus so much on the inputs to the algorithm and say more broadly what are the topics or what are the historical information that clinicians they look at. Okay, so you could also do that just by simply using Google's knowledge graph, and we have done that in some of our cases. So here is a case that the algorithm is saying that the patient's BUN is abnormal, and when you do a simple Google search here, Google says that abnormality of BUN actually can happen during the third trimester of pregnancy or in patients with severe liver damage. So if you could extract this type of contextual information that may not be present in your algorithm and provide those to your algorithm as a part of something called like a verification process, it might be able to capture more of the context that way and reduce false alarms and make the algorithm a lot more actionable. So with that, I want to actually now step back for a second and ask the question, do we really need explanations in medicine? And actually, it's not very intuitive. It depends on who you talk to. It turns out if you talk to the C-suites in hospitals, they like to standardize and come up with protocols. And they really want to come up with very fixed way of actions, responding to patient symptoms and diagnosis. Whereas if you talk to physicians, they like to have autonomy. They want to personalize care for patients. And really, it's not clear which way is the right approach. In fact, there are people who have advocated for medicine being more like a cheesecake factory. Every cheesecake factory that you go to is standardized, and they deliver the same type of cheesecake to you. So we also have this national quality metrics for various use cases. Like in the case of sepsis, we have the CEPON bundle. And so in this context, it actually makes a lot more sense to standardize so that you can get your quality metrics up and improve. Again, this brings me to this notion that we often make assumption about interpretability, and we are, I think, mostly focused on patients or care team. The healthcare ecosystem is a lot more complex, and something that is interpretable or useful to your healthcare team might not be useful to your hospital administrators or payers. Here is a simple example. Let's say that you have a patient with sepsis as the primary diagnosis, and this patient has already been for 72 hours on mechanical ventilation. And the algorithm, you have an algorithm that predicts that the optimal weaning time for this patient is within the next 12 hours. The question is, should you wean this patient or not? So here are two different decisions. When you start coupling pattern recognition with decision making, you might actually come up with contradictory decisions. Decision number one is start the weaning process. And the explanation is there are signs that this patient is able to have a spontaneous breathing, breathe on its own, and has normal blood gases. The second decision could be that do not wean, wait for at least 24 hours. And you may wonder why. It turns out if you look at the reimbursement for sepsis, there is something called DRG codes. And it turns out that if you have severe sepsis and you are on mechanical ventilation for larger than 96 hours, then you get $90,000 of reimbursement. If you are for less than 96 hours on mechanical ventilation, your reimbursement might be actually quite lower than that. So here is where, from a point of view of payers and hospital administration, you may actually have a very different view of who we should keep on a mechanical ventilator. Okay, that brings me to the next topic, which is issue of trust. And I'm going to go very quickly through this. There are a number of things that play into that. Explainability, interpretability is definitely very important, but also clinical evidence and harm benefit analysis and liability and fairness and many other topics that goes into this. So in terms of clinical evidence, I think we can say that clinical evidence, at least in my world, is very, very low. There are some clinical trials, but as of very recently, there are no results posted. And when we talk to FDA says that there are no legally marketed predicate device in this domain, in sepsis prediction. Similarly, in other similar areas. I think the situation is much better in the imaging world. And even in the imaging world, when you look at the examples, it turns out many of these AI systems, they're not really well validated. And that's why we are hearing these issues of generalizability and fairness, etc. And FDA has done a very good job of intended use cases and looking at the indications for use, but I challenge that there is still this issue of indications for use. When I peer review paper and what I ask my colleagues, at what level of missingness do you withhold from predicting AKI or sepsis or whatever it is, they typically respond back that there is no level of missingness, at which we don't predict sepsis or AKI. And this should be concerning. So I'm gonna quickly mention one area that we have been looking at, and that's the area of conditions for use of algorithms. And I refer that to that as algorithmic humility. So basically what we have done is we said, okay, you have an algorithm. Typically you take it to a new environment and you make your predictions. But why don't we incorporate some measure of algorithmic trust here? So you have, again, your algorithm, your input, it goes to an encoder. And then during the test time, we collect examples of representations produced by the algorithm. And when it comes to the test time, we ask the question, this test example and the representations that are produced, have I seen examples similar to that in the past? And if I have never seen examples of that in the past, I go ahead and I say, I don't know. This is an indeterminate case and I'm going to reject it, or I'm going to make recommendations that you should order extra labs for me to make a prediction. And if I've seen an example in the past, and then depends on those examples, did they produce correct predictions, how much of missingness they had, then I'm going to use that information to make a prediction. So that's the example of sort of maybe algorithmic humility or conditions for use, having an algorithm that says, maybe I don't know. So with that, I wanted to say that, machine learning has been quite successful. But I think part of that success is because machine learning had the luxury of defining its own performance metrics. And I think this is brilliant. If you can define your own performance metrics, you're going to do very well. But I challenge machine learning folks to think through the whole ecosystem of machine learning. And it's a lot more complex. And really the performance metrics needs to be, I think, a little bit broader and needs to be well aligned for these systems to gain wider trust and adaptation. And so we need higher quality evidence. We need to understand the culture of medicine. We need to have much better oversight. We need to think deeply about fairness and inclusiveness and unintended consequences of these algorithms. And then we need to get stakeholders involved in process much, much earlier. Anytime I had an algorithm that I had a clinician involved in making that algorithm, I was a lot more successful in getting it into a clinical practice, or at least have a quality study to look at the performance of the model. With that, I'd like to acknowledge my funding agencies and happy to answer any questions.
Thank you very much, Shamim. I think we have time for a one question. We're running a little bit late, but see if one comes in. If not, we can reserve some for later. Let's see. Okay, I'll have a question. So one of the themes that sort of was interesting to hear is these different scenarios you're describing for a doctor, and how they will actually require or use contextual information very differently if you're in the ER room relative to being in in some other situation. So do you think that the sort of the AI solutions will have to sort of take into account, it might be sort of utility or situational awareness? Do you think that is sort of going to be an important ingredient, rather than just, it seems like everything that you're saying is pointing towards these algorithms that just really focus on detecting sepsis, and just the whole ecosystem around it is ignored. And when you do that in the lab, when you're validating for a very narrow validation that seems to do great, but now you immerse that AI in the complexities of the real world, having to do varying situations in which a doctor might rely or not on supplementary information, and all given the situation, the AI sort of sinks. So, do you have any ideas of how do we actually bridge that, or is it just unbridgeable for the AI?
Yeah, I think for one, we have to move away from pattern recognition and think deeply about actionability and clinical decision making. And I think in other domains, I just listened to a talk by Michael Jordan from Berkeley a couple of days ago. He was advocating for exactly the same. And I think we should start thinking also about the intersection of AI, clinical decision making, quality metrics, which hospitals care a lot about. And it seems like there's a completely, those are the performance metrics that they look at, they're quality metrics. And then we have to also look at the health economics side. And as you see, there are examples that are very counterintuitive, and I can come up with some more examples that sometimes actually early recognition is not going to help the hospital in terms of their bottom lines. In some other cases, there are areas that they can invest into, let's say, improve fairness and equity, but again, it might be very, very costly. So how do you reconcile that? I think we haven't really looked at the ecosystem and intersection of all of these topics properly. I think we are just focusing too much on AUC and this very simplified performance metrics right now.
Okay, well, a lot of really cool stuff to think about and discuss in the general QA, because I think you bring excellent points. We will come back to these themes, but we will move to our last speaker for the session, Kyle Myers from the Division of Imaging, Diagnostics, and Software Reliability, the Food and Drug Administration. Title of her talk, AI-enabled systems in medical imaging, FDA research in support of regulatory pathways.
Thank you, Miguel. I hope everyone can see the full screen of my slides. Can you let me know, Miguel, if that's working?
That is working.
Awesome. All right. Yes, I'm Kyle Myers. I'm from the Division of Imaging, Diagnostics, and Software Reliability in FDA Center for Devices and Radiological Health. And what a great set of presentations for me to follow, and a lot of things that I'd love to respond to. And I'm looking forward to the panel discussion that follows my talk. So I'm going to be talking about AI and medical imaging from an FDA researcher, regulator's perspective. So I thought I'd start off by giving you some information on some recent CFR notations. My slides can be shared by the organizers and myself, so that you could see where we are today in terms of the products that have received marketing authorization by the agency. Starting in the upper left, we've been in the business of putting CAD devices, CAD-E devices on the market for a very long time, right? Since the late 1990s. So what's different in today's devices intended to direct attention to portions of an image that may reveal abnormalities is really the fact that the devices that we're talking about in this workshop, these AI-enabled devices, may not be, as our last speaker was talking about, quite as understandable or interpretable in terms of how they've taken training data and turned that into an algorithm that provides these kinds of pointers, as opposed to the kinds of algorithms we were talking about 20 years ago that were really developed to mimic expert radiologists. Moving on from that, we have a lot of devices that we are starting to allow to be on the market that go a step further and allow for classification of areas of an image. For example, determining that the ROI has disease or doesn't, or even make a recommendation for intervention. You can find more about how we code those and look for those in that reference there. In about 2018, we authorized the first CAD-T, or computer-aided triage system, and have allowed for about 30 of those, or maybe even more. It's hard for me to keep track myself from within FDA. A lot of different applications where companies are looking to develop aids for prioritizing the reading of cases so that time-sensitive findings are at the top of a reader's stack. Last year in 2020, we authorized the first device, an ultrasound image capture system that was AI enabled to support collection of images by technologists, achieving image quality on par with that of experts. And then, of course, there have been many other applications, and we've heard some examples of those today that have to do with image processing, like image registration and segmentation. I'm going to talk a little bit about image reconstruction and denoising and quantitative imaging, amongst other possibilities. So this slide was published, is a graph that was published in 2020 that lists FDA approvals for AI-based devices in medicine broadly. Although my talk is about imaging, I just wanted this to be present for completeness so you can see where this timeline started, and others have pointed to this timeline of about 5 years ago as well. More recently, and this was a paper that was pointed to by our last speaker, this paper on how medical AI devices are evaluated appeared in Nature Medicine just last 2 months ago in April. And one of the things that I wanted to say about this, and it really harks to what was just said about figures of merit, is this red circle here and the cautionary note of these authors that only 4 of these studies that were used to bring evidence to the FDA involved prospective data analysis. And what I would say about that is that, yeah, it's absolutely the case that FDA has a large majority of the studies that are represented in the imaging space as being approved based on retrospective studies. That's quite common for pre-market evaluation. We take a very risk-based approach to our device evaluation in general. And for a very long time, the imaging science community has recognized that evaluating a technology it has advantages in a retrospective study, because we're able to pull apart the quality of the information provided by an imaging device, whether it's hardware or whether, in the case that we're talking about today, it's AI software. And it allows for us to do some important subgroup analysis involving perhaps challenging cases or stress tests in a way that's least burdensome, gives FDA its expected evidence that a device does indeed provide additional information to the user. And then we understand that how that information is used in the clinic is something that's going to unfold over time as clinicians get used to the device and how it's providing value for them in their environment. And post-market studies can fill out the story regarding clinical use. So I'd like to point to this paper by Brandon Gallus and many co-authors that was published in Academic Radiology in 2012, the output of a workshop that brought a lot of very expert thinking across the community to speak with one voice around the consensus for this kind of approach for many imaging device evaluations. I'd like to turn the attention to what my title really said I would be talking about today, which is the research that's happening at the FDA to support device innovation and device review. So I just want this slide to get across to any of the, especially the students who may not be aware that FDA is populated by many more people than lawyers and reviewers. There is a very active research program and a great YouTube video on the left link tells you about our research office generally, and I'm going to be talking about the imaging research program and the work that we do to support device innovation and review. So our scientists wear two hats at the same time. We are researchers. We serve on teams as regulators, providing expert advice to the regulatory decision-making process, provide input, and often lead the development of guidances and policy. So our AI/ML research program at CDRH is quite broad because the questions that exist in the evaluation of these technologies are many. And so I'm going to give you some examples in the slides that come in the work that we're doing to support the development of novel approaches to expanding data sets for training and testing of AI/ML algorithms. I'm going to give you an example of the work that we're doing in CT denoising and quantitative imaging. I'm going to talk about work that we're doing to support the evaluation of generalizability and robustness of algorithms. And we have research efforts to streamline our assessment of CAD-T or rule-out software. I don't have a lot of time, so I'm just going to give you a handful of examples, and there are more that you can find by talking to me, my colleagues, or looking at our website. So to tee this off, I wanted to bring to your attention, for those of you who may not be aware, that we published in JAMA Network Open in 2018 a full in silico replication of an actual clinical trial that was performed to support bringing a novel digital breast tomosynthesis, or DBT, system to market in the United States. We humbly coined that project the Virtual Imaging Clinical Trials for Regulatory Evaluation, or VICTORY. And the tools that we developed included procedural models to model the breast. We have long been in the business of developing and making available state-of-the-art Monte Carlo X-ray transport computational models for doing the simulation of the imaging process, and we leveraged that for this project. And then we simulated the computer image interpretation, the image interpretation of the resulting images by computers, the reader part of an imaging clinical trial. And the conclusion that we drew in this paper is that we would find the same differences in performance between DBT and digital mammography that were found by the clinical trial that was submitted to the FDA. We would make the same regulatory decision, and we would do it in less time and about a third of the cost. And now we make those tools available. And what can we do with them to support model development and algorithm training? Both ourselves and many other groups are making use of our tools for these kinds of applications. So here's one example. This is work by Kenny Cha, published last year in JMI, where he looked at the potential for using synthetic images from the VICTORY pipeline to augment the need for annotated data sets for a breast cancer screening kind of application. And the results that you see here on the right show that if you only had actual clinical cases, your performance was this blue line, and he investigated what happens as you add more and more synthetic data sets in your training and then test on actual clinical images. So that says this is a tool that can be used to support developers of devices and bring down their need for actual clinical data. Here's another example. We appreciate, and there have been a lot of discussions of this point, that a company may have access to one clinical device and the data that results from it for developing an AI algorithm. In this example of mammography, imagine that you have one mammographic system and you've developed a successful AI algorithm, and you would love to be able to bring to the FDA a claim that you could apply your algorithm to a host of other imaging systems. Rather than the need to get images from all those other devices, wouldn't it be great if you had credible approaches to modeling data that would allow for you to bring down the amount of actual clinical data that you would need? And would FDA accept that approach? And so the goal here, and the effort that was undertaken by Zaraganian and published in 2020, was to look at a system that existed that you had access to, and a target system and a target data set, and use a CGAN to convert images from system 1 to system 2 and develop an AI algorithm that would be robust to the different imaging system characteristics. And what she found, here are some example images, the source image from the system that you have, a target image collected from the actual target system that you'd like to replicate, and the CGAN generated image. And you see perceptually, these look pretty similar, and her analysis shows that across an ensemble of images, the SSIM confirms the similarity. And moreover, she was able to show that this CGAN approach also replicated the imaging technical characteristics in terms of the fact that the source system and the target system had quite different pre-sampled MTFs, and the CGAN modeled results had an MTF that replicated the target system. This is a great example of an effort that we're undertaking that has a very statistical flavor. We have a lot of statistical efforts in our group because imaging clinical trials are highly statistical, and there are a lot of regulatory science needs for new statistics in AI to support, for example, applications where the reference standard is missing or difficult to achieve. This is an example from pathology, and this effort is entitled High Throughput Truthing of Pathologist Annotations as a Reference Standard for Validating AI in Digital Pathology. So let me take that apart. High throughput truthing means we're going to collect pathologist annotations in parallel in a high throughput way and use them in an aggregated way as a reference standard for pathology, because we all know pathology is often used as a reference standard for other modalities. The challenge is, what's the reference standard when AI is going to be applied to digital pathology, as we know innovators are wanting to do. We've heard some other examples this morning about how you might develop a reference standard from a set of readers. The key aspect of this work is taking into account the variability across the truthers who are doing the annotations as a reference standard. The example application from this work, and you can see a recent publication where you can get more information in the Journal of Pathology Informatics this year. The application here is estimating density, a quantitation task of tumor infiltrating lymphocytes across a very large number of ROIs. The deliverable will be a digital pathology data set with this reference standard, accounting for reader variability. But here's the real key, and the additional power of this work is that the statistical methods and software that we are developing and demonstrating here will be able to be applicable to other imaging modality applications where the reference standard is difficult, if not impossible, to achieve. And that's always the goal of the research labs, is choose an application that makes the problem concrete, understandable, real, but make the results, the deliverables, generally applicable, because we know the imaging universe is wide. Here's an example of some of the work that we're doing in quantitative imaging using radiomic features. We've long been partners with the Quantitative Imaging Biomarker Alliance, and that work too predates this new AI kind of space, back when we were doing more procedural QI efforts. But this work, the present application, is the analysis of bone texture to perhaps provide a more accurate evaluation of bone health than the standard biomarker of bone mineral density. And the team is looking at the possibility of using radiomic features derived from projections, which would allow for more accessible data sets and lower patient dose. And here again, this is a demonstration project that allows for us to look at issues related to dimensionality of the feature space, dimensionality of the null space of projection imaging, and figures of merit for showing that the approach matches the actual stress distribution that is, achieved by actual bone samples. I said I would mention some work that we're doing in CT image denoising in the proceedings of the SPIE Medical Imaging Conference that just took place in February of this year. We presented a comprehensive investigation of deep learning algorithm performance across a large number of algorithms for a large number of image acquisition parameters in CT and data pre-processing steps. The goal here is for us to be able to have more streamlined decision-making for AI-based denoising submissions. This is something that is quite avidly being pursued by a number of investigators, understanding the need, the desire to bring down CT dose. And what we're looking to do here is to allow companies to make claims beyond the image data sets they may have for training and testing by understanding the image characteristics that change by the different ways that you acquire the images, which ones would be such that a denoising algorithm would be robust and which ones the image denoising system might be sensitive to. And the conclusion that was drawn is that those that make significant changes to the noise power spectra are ones which the network architectures are going to be more sensitive to, which makes sense from an image denoising perspective, but now we have some data to back that up. We make a lot of tools available, and we do this in two ways. Maybe you have heard of the Medical Device Development Tool Program, which is a way that we qualify an approach for providing evidence to us regarding the ability of an algorithm to perform. In the AI space, an MDDT could be a data set, or it could be a statistical package for AI algorithm evaluation, or a framework. If an innovator of an MDDT brings that tool to us and it's qualified, that means an innovator who's bringing a submission to us for something that they want to market, they can use that MDDT for the evaluation of their device and have confidence that we, FDA, will not be asking a lot of questions about the suitability of that evidence, because we already put those questions to rest in the MDDT qualification process. So it gives confidence to industry and it gives efficiency to us. Another program that we're doing a lot more talking about these days is the development and publishing of a catalog of regulatory science tools. Now, this catalog is specifically populated by CDRH scientists. MDDTs can be brought to the FDA by external stakeholders, as well as we have some tools qualified that came from the CDRH labs. This catalog gives you a very open eye towards what the labs are developing at various stages of maturity. They're available online for public evaluation and use because they're not qualified yet, and some may not be taken through that set of hoops. If you would be interested in using one of those tools as part of a submission to the FDA for a new device, then you would want to ask for a pre-submission meeting to talk about how that tool would be valuable in your application. I point you to our website where we make imaging system simulation tools and software for doing imaging clinical design and analysis. That's all there. We, as I said, both participate in guidance, lead guidance, and are active in publishing. And these are some of the papers that I would point to that give our perspective on the state of the field in medical imaging and radiation therapy. And my slides, I'm not going to go through this, have a lot of additional FDA resources, recent guidance, the AI/ML action plan that we put out earlier this year, and some recent reclassification orders. So I'm going to summarize by saying what we've all been saying, that medical imaging is a leading area for AI in medicine. We've been at this a long time, but what we're seeing now are novel thinking and novel applications. And the research labs are poised to speed device innovation and more efficient regulatory decision-making. We sit in this wonderful space between innovation and evaluation. addressing gaps in device evaluation methods. We don't compete with industry. We're trying to support innovation, putting methodology and tools into the hands of stakeholders to ensure that the devices that are approved by the FDA, cleared by the FDA, are safe and effective. So I'd like to thank my colleagues at the Division of Imaging, Diagnostics, and Software Reliability. Obviously, this was not 2020, our 2019 Summer Student Poster Day. It's a great place to be in this exciting time of AI. And so thanks for the opportunity to share some of our work.
Thank you very much, Kyle. We have time for questions. Start my video. Here we go. Okay, so this question is related to the recon and denoise models. Do you think image quality can be enough to evaluate an image reconstruction model, or the downstream task, diagnosis, or image processing should always being taken into account in validation or as of the objective of optimization?
I'm not sure I understand the question. We certainly are strong promoters of task-based evaluations. The challenge for CT denoising is that, CT images, like all imaging modalities, exist with very generic claims around what kinds of images will be collected for what kinds of purposes. And so the approach that we've taken is to, first of all, look at the technical characteristics of the images, like I was just showing, impacts on those first level measures of imaging performance, like MTF, noise power spectrum, low contrast detectability. And then the goal will be and to support even the use of simulation to have companies evaluate surrogate tasks, something that may probe high frequency content, as well as what low contrast detectability tasks do, which we appreciate is low frequency content. If somebody wanted to make that more clear for me, what you were asking, I'd be glad to try another stab at that question.
Okay, and then here's the next question, and what we'll do while we do that, Kyle, can you stop sharing your screen?
Sure.
Then we can get a better picture of you. Okay, great. So second question is the hard one, or maybe it might require a long answer. How do you validate AI algorithms for imaging systems, either virtual clinical trials or clinical trial?
That's always a question of how good is good enough. And, we are in one place in the pipeline in the evaluation, and our job is to ensure that devices have reasonable assurance of safety and effectiveness. And so we have the kinds of approaches that you can find on our website when you look at the summaries of safety and effectiveness data, or the data that was submitted, understanding that more information will come. Because we're always in this place of trying to, not hold up technology that has value too long and not let it out too early. So one of the things that I guess I would say about that is, the reason that we make use of the kinds of task-based and ROC technologies with retrospective studies is that gives us evidence. It's not the same as the evidence that might be found in the clinic later. And we understand, and this is true of hardware technologies too. We get enough data to have some belief that the devices will be safe and effective. And we're relying a lot more these days on post-market data to round out the story. And that's in fact why we've established the National Evaluation System for Healthcare Technology and with our partners at the Medical Device Innovation Consortium, and support from industry, so that we can continue to collect data, make that available to users, to practitioners, so that they have a better understanding of device performance and value.
Great. At this point, I'm going to bring the rest of our speakers and our keynote speaker back, so we will have a panel. I would please, if you're in the audience, start sending your questions for the panel. other panel members can ask questions from each other. I do have a question for Kyle and also for everybody. And then we have a few excellent questions that we left behind that were sort of interesting. So the first one for Kyle is, typically what, at least where I'm familiar with the FDA, where regulatory approval is really focused on, sort of standard ROC techniques and being able to show that you can detect disease by a given AI in this case or device. Now with a case of AI, have you started thinking? And I'm sort of really sort of thinking about what's going on in the AI world of other things such as things that are coming up about like fairness. Like, the fact that the AI might be trained in a data set that is a subset of the population and might not do as well for other sectors of the thing. So these are things that perhaps they were not so present before, but now with AI are becoming important. Is the FDA thinking of these, and how is that going to be incorporated in the regulatory approval or not?
Well, we're certainly thinking about them, and our CAD guidance, tells submitters what kinds of information they need to provide to us regarding their testing protocol and descriptions of their data set, as well as their training. Whether we, kick that up a notch in terms of, how much we push for, increased fairness, because we certainly are looking for evidence that devices perform across the US population. And again, there's always this yin yang for us around, what kind of cost are we going to impose on a company around how much data needs to be, acquired and used for training and testing to get on the market, and how much we're going to allow for the system continue to improve over time. So, allowing for the company to get a first, software algorithm out there, get some revenue and grow their capabilities. Tough question. Love to hear what other people think.
Others in the panel want to take a stab?
So one thing I thought it was interesting is that maybe that issue was not present before and now it is, but is it that it was not present or that we weren't aware? Because I don't think radiology residents necessarily are trained using images that also represent the variability that they should. And well, we're talking, like I mentioned during my talk, perhaps we're setting the AI to higher standards that we're used to for human performance, and I wouldn't be surprised if the same biases are present in human training.
Right. And probably, we're understanding this more and more across all kinds of devices, the kinds of things that FDA regulates are very broad, right? Cardiovascular implants. And we've heard, Shamila talk about orthopedic implants and device different, or patient differences. So I think it's a very cross-cutting issue.
Any other comments? Or should we move to another question? Okay, here's a question that was, I believe this was for Ioannis. No, this one was for Sharmila. I think, I'm trying to remember. This was the question. What do you think about double reading by two different AI systems? I think that was for Ioannis.
Yeah. So yeah, for sure, two different AI systems, assuming that the AI systems perform, similar to each other, but not, that they actually give us new information. So actually, funnily enough, a month ago, I wrote in a application, part of the study I would like to do, and is as I showed for tomosynthesis, the idea of the second reader being an AI, and of course we could have a second AI, but perhaps if the human reader can read assisted by an AI, that AI should be different than the one that acts as a second reader. And then in essence, we have, yes, two different AIs, hopefully providing different information, and that are checked, let's say, or taken advantage of by at least one reader in the first case, and then the arbiter where it's needed. So I think that kind of setup would actually work, has a potential to work really well.
Any other thoughts? I mean, as a follow-up, I'm just thinking of this scenario. Are we going to be in the situation where patients might want to have access to their images and run it, pay for, other companies that offer a better AI, and they will have the right to run it through AI of their choice? Is that going to be a situation we might have?
Okay.
I could see that. It's not a whole lot different from them taking their images and going to get a second opinion. So I could certainly see that being something that they could get access to perhaps on the web, and interesting future.
Yeah, it would be good to have some medical professional being involved in that second opinion, not just an AI only second opinion. I just upload the images to a website, pay $10 and get an AI only opinion, no matter what it is. And but yeah, I mean, supposedly the images are property of the patients, right? Or at least now we're getting that idea. So for sure.
Sounds good. Here's another. I think this one was asked to Shamim. It's a little bit of an open question, but I think some of you might have thoughts. Here's the question: what are the factors do you think that limits the lifespan of AI algorithms? I imagine that when it says the lifespan is, when it becomes outdated. And how do you? I don't know what, how do you actually prevent from that happening, or what do you put in place from that happening? And what are the factors that could actually make, aside from competitors getting better, what are the factors that might make an AI algorithm outdated?
I can give you a sort of machine learning answer, which is we often assume something about the distribution of data. And we all know that there is this problem of data distribution shift. Simply said, populations, they change, or from one institution to another institution, they change, or even within the same institution, they sometimes change over time. And then, we talk about data drifts, which is within the same distribution hospital, you may introduce new sensors, new way of measuring things. So, in my work, we observe that patterns of ordering of data or data missingness is very different across different centers. Like, I give you one example. With early prediction of sepsis, it turns out whenever there is clinical suspicion of sepsis, clinicians, they order extra lactate labs or some other labs. Sometimes these AI algorithms, they can pick up on those patterns. And then when you go to a new institution and now they have a point of care technology and they order that lab more often, the AI thinks that actually patients there are sicker. So there is a lot of factors related to, workflow related factors, population characteristics, and even like prevalence of disease, incidence of disease. We always come up with these thresholds, and we all know that these thresholds really depend on the prevalence of disease, especially if you're optimizing for PPV and NPV. So you have to pay attention to those. So there are myriads of factors. So that's why in my work, we said we cannot boil the ocean, but at least we can say what are the boundaries of our device. And if we observe a patient that is very different from what we have seen in the past, we just say, I don't know, or you maybe need to improve the quality of data, or go figure it out. I don't know. I'm not omnipotent. I don't know everything.
Any further thoughts?
I guess specifically in the area of breast imaging, so we're used to the image processing that the raw mammograms are put through changes immensely across years, and device manufacturers introducing versions, and sometimes we've seen the same woman screened every 2 years 5 times, and you look at her mammograms, of course she ages and her density goes down and everything, but the field of the mammograms really do change quite a lot. And I wonder if, well, now we don't only have human readers that might be able to adjust across versions easily, but as new versions come out every year or two or whenever it is, then if they're going to be updated as quickly by the AI manufacturers. And of course, if they don't have data, it's really hard to update the training. So it's kind of the chicken and the egg.
I think you're right, because once the base technology becomes obsolete, then the AI algorithm will become obsolete. So if 3 Tesla MR imaging is obsolete and we're all doing 20 Tesla imaging, then the models tested on 3 Tesla are totally obsolete. Once low dose CT becomes the way we go, then the original old algorithms, I'm just saying, I don't think these exist, on the very highest of dosage CTs about 20 years ago, will clearly be obsolete. We run into this every time you're sort of trying to get data from your archives, right? You can go back 20 years, but in 20 years, the way the radiologists even reported the findings were very different. So when your gold standard that you've used is obsolete, it becomes obsolete. This is a derivative technology in some senses. So I think the obsolescence comes largely, the biggest obsolescence comes from the base set, I think.
My other favorite example is, so there's a PhysioNet database hosted up at MIT, and there is this congestive heart failure database. And people have been building classifiers distinguishing between normal sinus rhythm and characteristic of congestive heart failure patients. And it turns out heart rate is a predictor. And the reason was, at the time that they were collecting that database, patients were on one type of medication that was artificially elevating their heart rate. And that medication is no longer being used. So there are all of these temporal factors, again, that could affect how valid are your AI.
Well, thanks. Here is another one that will, I think will we can give some thought. Where do you think there is more room for to grow, or at least more immediate growth? In new AI algorithms or in new imaging systems? Where should we, is there more room for improvement right now? Philosophical a little bit, but anybody ventures to give an answer to that?
I can say in my world, we have this problem of dark matter or dark energy, whatever you want to call it. We have a very narrow view of what we are measuring on patients. We often talk about data deserts. I think we need to have better measurements on patients in different settings. And often we are limited by what is being ordered by clinicians. So we have a problem of unknown unknowns. If a clinician is not suspicious that the patient has a problem, maybe you don't get a measurement on the patient.
Okay, that's interesting, right? Because that was, to some extent, a little bit different from our keynote speaker yesterday, who was actually talking about over-testing and so like, trying to use AI to do a better job than physicians in triaging who gets tested, and who's in the, so it seems like it's in different areas, there's maybe over testing or not right of the triaging who gets tested, but in other areas, you're operating with too little data, which is interesting.
Well, it's because our cost functions are detection rates. If we broaden it a little bit more and bring into actual cost of testing and potential harm to patients and have more realistic cost functions, then you get something that is more realistic, right? But we haven't gone there yet with ML, machine learning, so much.
So in the breast imaging area, and especially the mammography, so keeping within mammography, let's say not new systems that replace mammography for something completely different, but within reason of the same modality, the first thing that comes to mind is, we always say, and I think most people in the breast imaging community would agree, that they would rather have a bad mammogram read by a good radiologist than a good mammogram read by a not so experienced radiologist. So I wonder if you can apply that to this question. and say, well, if I have to improve the mammogram or the reader, and this happens to be an AI reader, then I'd rather improve the reader. Maybe too simplified, but.
No, that's certainly an interesting point of view. Okay, we will have to, now the questions are starting to pile up. This is what happens. Sometimes at the beginning, people are shy, and as you start talking, people start thinking about other interesting questions. Okay, so here's a good one. Given the discussion of bias from the characteristics of the training data set, would it be better for AI tools to be fine-tuned on local data? And what concerns would the FDA have for that idea? So the idea is of actually doing sort of, I don't know, some transfer learning or something of fine tuning your, basically the AI algorithm. And going to Ioannis, this is probably what the radiologists were doing all the time, right? They're fine tuning to the patients they see. So what are the thoughts about that idea?
Yes.
When we make our decisions, we pay attention not only to the, device performance data that we get, but also the claims that a company makes. There could be, a space for a company to say, this data, it came from this, local area, and this algorithm will be deployed in this local area, and track that. And we haven't seen that to that, a narrow way yet, but it would raise some really interesting discussions that in my place.
I can briefly comment. I think it's a great idea. I think it's a little bit of wishful thinking though, because it's very hard to get hold of high quality gold standard labels at every new institution. That's a very expensive process. Mm-hmm. Like for my sepsis algorithm, I can predict sepsis based on 50, let's say, clinical data elements, but for getting the gold standards, I need 3 times as much, and I need very diligent work to be able to extract the right labels. So I think it's difficult.
Okay, and to follow up, I think the next one is actually, there's a few questions that are all related, and the next, I don't think the audience can see the questions from the other people in the audience, so it's sort of interesting that everybody sort of is focusing on a similar theme. So this is for Kyle. Dr. Myers, can you please comment on the FDA position on continuous learning? So this is a little bit, again, about fine-tuning things. And my understanding is that it is not allowed, and a model must be static over time. And this is an issue of a tension between models wanting to continuously learn and the inability, or at least it becomes much harder to actually regulate something that is changing day by day.
Correct. And some, but not all, might realize that we had a workshop a year ago where we talked about learning algorithms and had a lot of experts, both from academia and from companies, talking about the obvious potential for learning algorithms, but not a lot of, consensus around how we might have safeguards that would assure that the devices improved over time and didn't, for any number of reasons that we all might expect, degrade. So we're still in this process of talking about it publicly, and that's part of what you'd find in the AI/ML action plan, and collecting information from stakeholders and kind of in a thinking and policy development mode. It's not a question that if it was easy and we all were in the same place around what we thought was the right thing to do, we would be there already, but there just isn't a consensus yet on how to approach that. Love to hear people's thoughts.
Anybody else wanting to add something to that discussion about the tension between regulatory or keeping an eye on what the AI is doing and continuous learning and modifying your algorithm?
Yeah, I mean, one of the issues with continuous learning is handling or ensuring patient privacy, especially with systems that are cloud-based. Ensuring patient privacy on the top of that, ownership over data, Like I come from the UC system. The Office of President says any transformational data is also health data and is owned by the University of California system. So good luck if you are trying to use some sort of representations of UC data to update your model. On the top of that, as I mentioned again, how do you ensure that local data that you are using for continuous learning actually has the right quality in terms of labels? Well, both input data as well as labels. So I think we need a little bit of innovations in that domain. I just saw a paper published in Nature on swarm learning. They are using federated learning. And there's no place in the entire paper that they talked about the quality of input data.
Shamim, as a follow-up to that, I was wondering, and not being an expert in this, is there what is the role, or is there any role in of learning in a non-supervised way, either semi-supervised or self-supervised? Are those things already in there? Or obviously it's very different to train an AI to diagnose and detect things than just doing some of these more mundane tasks that don't have such high costs if you make a mistake. So is that something that people are playing around in the continuous learning, just learning without the labels?
So I think, there are some applications of adversarial domain adaptation, which you say, I want to predict X, and I want to learn representation that maximizes my ability to predict X, but I want the same representations to minimize my ability to distinguish between hospital A versus hospital B. So it's sort of, you're learning representations that are denuanced. And for this, you actually don't need to have labels on the second hospital. You just need to know which hospital the data came from. So this is a good example of sort of unsupervised learning that helps with denuancing. You could also apply the same concept to different racial groups. You could say, I want to have a representation that maximizes my ability, but minimizes my ability to tell which racial group this model came from. So I think there are some opportunities there in terms of unsupervised learning.
Commenting about this conversation, one of our somebody in the audience who actually asked one of the previous questions says about talking about continuous learning. It's not like board certified radiologists should stop studying. So the idea that the AI has to stop learning, but the radiologist is able to keep updating their model of how they do things.
Sure.
Any thoughts on that?
We have many examples of algorithms that have come back, close to 20 times with updates and new performance data. And that guardrail is not something that the community said a year ago that they, largely wanted to see go away yet. That we don't have enough ways yet of ensuring that if we all take our hands off that, guardrail or let the car go without those guardrails, that we'll be sure that it stays on the road. So.
Okay. And I think we have one question. I want to finish with a larger question to see if to hear your thoughts. If you want to think of one thing that will help us gain trust in the users, the doctors, in using these AI, so they just do not, some of you know, do not just altogether ignore them, like it's happened in the past, or on the opposite. On the other hand, that they just blindly follow them without questioning them. So, and in doing so, perhaps even diminishing their ability to do these tasks because they're just relying more and more on the AI. What do you think? What are the things that we need to take into account, or we need to do in order to prevent that and sort of have the ideal situation in terms of merging AI with the doctor's opinions? I know it's a hard question.
It's not really, right? It's when you introduce any kind of new tool, any kind of new therapy, anything, you expect that the medical profession will weigh things appropriately. AI is going to be no different than any other technology at this point in time. You could introduce a new imaging technology right now. You could introduce a new robotic surgery technology. Somebody may or may not adopt it depending on their, their preference, their access. There are different things associated with it, I feel. And I think the medical field is going to balance AI in exactly the same way that they balance any other introduction of anything new.
I think as radiologists, we'll see if it does their job easier and better, then they will use it, even if they're suspicious or and distrustful at the beginning. Then if it's implemented correctly in the workflow, so that it's not a headache to use, then people will, if it should correctly, if it does well enough, then people will tend to naturally incorporate it into their everyday work. Maybe it's too naive, but I think a lot of, at least in radiology, a lot of technology hasn't been taken up really massively because of workflow. Especially radiologists have less and less time to do their work, and whatever slows them down is the number one turnoff.
Also, there's that evil word, which is reimbursement, right? For the amount of time, the amount of cost, the cost that nothing is going to be cost-free. To assume that a technology like AI, just because the model has been built, is going to have no hidden costs and should cost cents to the dollar like it used to in the past. I think if one comes in with that and reimbursement doesn't keep up with what actual costs are and so on, that's going to be the other motivator. I think the other real motivator for health systems, forget radiologists per se, it's going to be the reimbursement pathway, which we haven't talked about at all.
Again, being idealistic, one of my mentors told me, if you can save money, save lives, and save time for clinicians, then they're going to use your tool. But there is also a lot of inertia in medicine, and as I mentioned in my talk, sometimes decision makers are not clinicians. It's C-suite, and they have completely different objectives.
Yeah,
I think increasingly clinicians are realizing that they don't have a whole lot of power. I mean, they whine about things, but if somebody says you have to use this tool, you have to improve this quality metrics, sort of they have to follow that. And I'm not saying that I think in many cases, actually, clinicians are right, because a lot of these quality metrics comes from CMS, etc. They are built for population-based, and they may not be optimal for this patient that is in front of the clinicians. But nevertheless, they have to follow those. So again, there are many stakeholders, and you can't say, what is the, golden bullet here. You have to look at the whole system.
Okay, with that, I want to thank you all. It's noon. We've had a great Q&A. Thanks for participating in this session. Thanks for taking the time. Some of you it's getting late in Europe, so thanks for logging in. And for those in the audience, thanks for sending all those great questions. And a reminder that tomorrow we have the last day of our virtual summit, and the topic is going to be AI and COVID. And it will start at 9 a.m. It will have the same format with a keynote speaker, followed by 3 invited speakers, and then a Q&A.